Good morning. Everyone will take their seats. Call the meeting to order of the Oversight Committee. It is now 8:31 a.m. We'll move to item 2, our roll call. Dr. Hernandez, please proceed with the roll call.
Thank you. Good morning. So roll call. Let's see, Dr. Cummings?
Here.
Ms. Payne? Mr. Margot?
Here.
Mr. Montgomery?
Here.
Dr. Rice? Here. Dr. Rosenthal?
Here.
Phil, sorry. Ms. Taylor? Okay, we do have a quorum.
We are missing one of our Oversight Committee members this morning. Dr. Patel previously notified CPRIT that he would be unable to attend today's meeting. I will entertain a motion to approve an excused absence for Dr. Patel.
Second.
All in favor, vote aye.
Aye.
Any opposed? Motion carries. Let's move to item 3, adoption of minutes. Members, you have draft minutes from the August 21st and September 25th Oversight Committee meetings in your agenda packet behind tab 1. Are there any corrections to the minutes as circulated? Hearing none, the chair will entertain a motion to approve the minutes of the August 21st and September 25th Oversight Committee meetings.
Second.
All in favor, vote aye.
Aye.
Any opposed? Motion carries. Item number 4, public comment. Our next agenda item is public comment. Texans created CPRIT. Opening our meetings with public comment underscores this board's commitment to transparency and accountability. Mr. Ellis, has CPRIT received any requests to provide public comment?
Sure.
Very good. Let's move to item 5, the CEO officer report. Good morning. Ms. Doyle will provide the Chief Executive Officer's report.
Good morning, members. It has been a busy fall for CPRIT, as you will hear from our reports and presentations from our program officers, our staff, and our advisory committees. This work will only accelerate as we look forward to 2025 and the upcoming legislative session. Earlier this week, Lieutenant Governor Dan Patrick issued a press release announcing a new major legislative initiative for the Texas Senate, the Dementia Prevention Research Institute of Texas. I bring this to your attention because in his introduction of DPRIT, which will be structured like CPRIT, Lieutenant Governor Patrick recognized CPRIT as one of the most successful existing health programs ever created in Texas. It is a model of what the state can do in an area of medical research on a specific disease. This investment draws leading researchers and companies to Texas, leading to their further investment in our state. That CPRIT now serves as a model for what a state like Texas can do when we laser focus on making strides on a particular disease is a testament to your work as an oversight committee and the commitment of everyone in this room and across the state at our institutions, our community organizations, and companies. That commitment that we have made to accelerating innovation in prevention, detecting, diagnosing, treating, and curing cancer. Today, you will consider 22 award recommendations totaling $89 million, resulting from CPRIT's latest efforts to identify the very best science and strategies to address the burden of cancer across the state. 15 years ago, almost to the day, your predecessor members on the Oversight Committee approved the very first CPRIT award, a recruitment award to Dr. Ralph Kittler. And today, you will consider the 325th recruitment award. That's quite a milestone. It's one thing to say we are laser focused on our mission. It's another thing to carry that out every single day. And you provide guidance to our staff and to our grantees through the Oversight Committee program priorities. 10 years ago, again, almost to the day, this Oversight Committee adopted CPRIT's very first program priorities. Those priorities, which you will consider today, have shaped our portfolio, from CPRIT's emphasis on childhood and adolescent cancer research to the TREC program to attracting innovative companies and standout scientists to Texas. The progress we have made is also a testament to the hard work of CPRIT staff. We've added 3 new members to our team since we last met: Grant Accountant Glenda Bearden, General Counsel John Ellis, and Chief Financial Officer Grant Weaver. I am thrilled that they are here, and you will see their contributions to our staff over the next several years. I'll end my report by looking forward to the upcoming legislative session. We have spent these past few months meeting with legislators and their staffs to update them on the progress CPRIT is making. And now that the election is over and everyone's attention turns to the Capitol, we will increase our outreach efforts. As you know, CPRIT's main legislative request this session is to increase the number of allowed full-time employees by 10. The need is obvious. We have more than $1.5 billion under active fiscal and programmatic management. The opportunities and obligations to meet with our grantees across the state and increasing cybersecurity issues drive this request. As I reported to you in October, CPRIT has exceeded our FTE cap. I have notified state leadership of this issue in the letter that I included in your packet at Agenda Item 17, and we will continue to keep them updated and you advised. So with that, I will stop here and answer any questions that you have.
Are any questions or comments for Ms. Doyle?
Just a brief comment. I mean, you're very kind, Ms. Doyle, to compliment us, but the real compliment should go to you and the staff.
Yes, here.
But that's where the real work gets done, and we appreciate you all very much.
Yes.
Well, thank you for that. And this incredible leadership that the Oversight Committee has offered has, we are really seeing the benefits of consistent commitment and continuity, and that has been enormously helpful to us as a staff. Thank you.
Don't forget our friend Vince, who's not here, the compliance department,
Yes.
which is, of course, the backbone.
Yes.
Yes, it is. He's watching, no doubt. All right. And on behalf of the Oversight Committee, we want to welcome our new team members. We're highly anticipated. So welcome and hit the ground running. All right. We'll move to our next agenda item. This will be item 6. Oh, perfect. Mr. Montgomery, our Chief Compliance Officer report and compliance certification. The chair recognizes Mr. Stephen Nance to present the Chief Compliance Officer's report.
Good morning, committee. You'll find our report behind tab number 3 in your booklet. Just a couple of quick, highlight just a couple of quick things just for this past quarter, and then we'll go into our yearly recap, which we always do in our November session. So for the end of October, we had 9 entities that didn't file reports in a timely manner, which is well under our 28 self-imposed threshold. So we're very pleased about that. For this past quarter, we also completed 571 financial status report second level reviews, which is again just an incredible number that our grantees are submitting. We also completed 15 enhanced desk reviews for this past quarter. And for our match reviews, so far, we've completed 7 annual match reviews for this past 3-month period for almost $9 million in match expenses being reviewed. And I'm pleased to announce that there were no unallowable match expenses for that almost $9 million that we reported on. And then lastly, for the quarterly recap, we had 2 new grantee trainings. We've also incorporated with our new grantee trainings, we've incorporated some additional technical assistance training that kind of goes along with that. Once our new grantees for our product development are ready to submit their first financial status report that has expenses, we're actually doing a walkthrough with them and their grant accountant to really help them set up the ledger correctly and make sure that all of the expenditures and support documentation is put in a, that they have it all and that they're putting it in the proper position. And so far, we're getting very good feedback as far as timeliness, and it's going through reimbursement a lot quicker, but we'll have more detail on that later because, we've only done a few of them. So just wanted to let you know about that. And now for our yearly recap from last fiscal year. Touch on briefly. So our number of delinquent reports in FY24 averaged 26 a month. That's a little bit higher than last year. So we're, there's still work to be done as far as that goes. But again, it's definitely below the self-imposed 28. But again, there's always reason to continue to push hard and look to make sure that those reports get submitted timely. Last fiscal year, we completed almost 2,200 FSR second level reviews, which is just a phenomenal testament to not only our group, but the entire CPRIT staff, grant accountants, operations staff as well, because they all have to touch every single one of those in the process. And then for training and education, compliance staff, along with other CPRIT staff, provided 40 grantee trainings this past fiscal year, which is just a phenomenal number. It's an increase. We had 34 the previous year. And this includes new grantee trainings, new authorized signing official trainings, our annual trainings, and then also those FSR technical assistance trainings as well. And then lastly, I just wanted to briefly touch on the match expenditures reviews. We did 21 annual match expenditure reviews for our product development grantees in FY 2024, totaling almost $30 million in expenditures. And there were only $302,000 in unallowable expenses. So roughly around that 1% mark, which I think is just phenomenal. And just to give you just an under the hood on those, primarily the reasons for those unallowable expenses, by and large, was expenditures that had already been counted, if you will, in a financial status report. And then the others were just really minor as far as unallowable late fees and things like that. That concludes my report. I will happy to answer any questions that you may have.
Well done, Mr. Nance. Might want to up the sarcasm just a little bit, but admirable effort. So,
Vince
thank you.
told me to keep it calm and level. He
We gotta leave room
provide the
for Vince.
sarcasm.
Yeah, I hear you. Thank you.
you.
Are there any questions for Mr. Nance?
Just a quick clarification. So what happens with the unallowable travel costs? Do they give it back to you, or what does that mean?
So we catch it we actually catch the unallowable
Yes.
before they're
Before they do it. Got it. Okay.
they're allowed. So it's just
Yes, sir.
an unallowed
Wonderful.
amount.
Thank you.
Thank you.
All right, very good. We'll move on to our compliance certification. Turning to the certification of the award slates that we will consider today, Mr. Burgess provided the written report certifying that the proposed prevention, academic research, and product development awards and review process complied with CPRIT statute and administrative rules. Mr. Burgess is unable to be here today. Are there any questions for Mr. Nance? Thank you very much for your report. Let's move on to our next agenda item, which will be item 7. We'll start our program activities section. The chair recognizes Ms. Magid to provide the prevention program update. As part of her update, she will seek approval for the proposed fiscal year 2026 RFAs for our consideration. Following her update, she will introduce the Program Integration Committee's grant award recommendations. And after Ms. Maga's update, Mr. Carlton Allen will present the Texas Cancer Plan for 2024. Welcome.
Welcome
Good
to
morning.
all of you as well. Good morning. And I just heard from Vince, and he in fact is watching. So he wanted you to know that he is hearing all of your remarks. So first I'll go through the program update, which can be found behind tab 4 in your books. It's short and sweet. The first cycle, which you will hear the program recommendations today from the PIC, is the 25.1, and we started with 24 applications received, and we'll be announcing the results of that in just a minute. For 25.2, we have 3 RFAs that are released. The application period closes in December, and you will hear about those awards in May of 2025. The next item I'd like to bring to your attention is the request for application. The program is recommending the release of 3 RFAs, the same ones that have been out last year and currently. I'll just briefly go through the 3. The first is the dissemination of CPRIT-funded cancer prevention and control interventions. And this is the one that is successful CPRIT projects apply for to teach others and to make toolkits and other materials available for others to implement their successful programs across the state. That one is for up to 3 years for a $450,000 maximum. The next is primary prevention of cancer, and it's for eligible projects up to 36 months in duration that will deliver interventions that improve cancer-related health behaviors, including tobacco use, obesity, alcohol misuse, physical inactivity, unhealthy eating, HPV, hepatitis B vaccination, and environmental occupational cancer exposures. And the funding is broken down into different types of projects. We have a new project, and then an initial expansion award, and then a maintenance expansion award, and you can see all the funding amounts listed there. The final RFA is the screening and early detection RFA, and these are for eligible projects up to 5 years in duration that will deliver clinical services in cancer screening for breast, cervical, colorectal, liver, and lung cancers according to national guidelines, as well as pay for diagnostic treatment. The components of the projects are also listed in your update. Evidence-based, they must be comprehensive, they must cover at least some medically underserved counties in Texas, and we really focus on the collaboration between the grantee and community partners. The funding amounts are listed there. There are 3 different ones, the same as the primary prevention: new, initial expansion, and maintenance expansion. Those are the 3 RFAs we would like to propose to be released in FY 2026. And you can see some other activities. I'd like to call to your attention, just to highlight the fact that you'll soon hear from Carlton about the Texas Cancer Plan, and I'd like to thank him and acknowledge him for the tremendous time and effort he has put into this plan. It's been a whole year interviewing others and gathering data and information, all while still fulfilling all of his other program responsibilities. So I'm very proud to let him present the Texas Cancer Plan, and he will do so after I go through the award recommendations. Are there any questions before I proceed with the award recommendations?
Good morning. Thank you. I wondered, and we've talked about this in the past, and maybe this is just a placeholder question and we can have a conversation, offline or and through committees, but wondering how we measure impact of programs. And I know before we've maybe reported on number of diagnoses that have come out of some program, and I would just be interested in us thinking and talking about impact, if there's ways to do that that are better, more effective. How does the impact, how do the number of diagnoses compare to the number of diagnoses in the community, and how you think about, you know, its relative impact across a community, et cetera. So just wondered about impact.
I'm sure I'd be happy to have I think that is a lengthy conversation that we can, have another time. We do measure, the numbers. We have metrics of the numbers of screenings, the numbers of diagnostics, the numbers of precursors that are found, and the number of cancers detected. It's hard to compare it to the out in the community, because of our population is unique. It's underserved and uninsured, and oftentimes these people have later stage diagnoses, or they wait to get their screenings because of many barriers, financial, physical, and et cetera. Rural access is an issue that there's just not the service delivery in all of the counties in Texas. In fact, some people have to travel up to 200 miles to receive, say, a diagnostic colonoscopy. And so it's just it's not apples to apples to compare it to the larger community.
Thank you.
But I'm happy to continue on the conversation about impact.
Thank you.
Dr. Rosenfeld.
Just to quickly follow up on that, in a lot of reports on screening, the outcomes are more than how many cancers are detected. They're on number of lives saved and financial impact of detecting early disease. Are we doing analysis of financial impact and mortality from our screening programs?
Well, in fact, every year, the cost of cancer in Texas, the economic assessment report contains that information. So the new one will be coming out next month. So you can see that. And we use the precursors detected. It can also be roughly translated to lives saved as well, because those could have developed into cancer. So that's a one indicator of what could possibly have been cancer.
Is there any control group that you could compare it to? People, who didn't receive screening or got placebo screening, or another population, say, in another state that didn't receive screening?
As far as I know, those numbers are not readily available.
Okay, thank you.
Sure. Any other questions before I move on to the awards? All right, so the awards are in your proposed awards booklet, and the PIC has recommended 8 awards to be to present to you today, and I will go through there are 3 different mechanisms. 6 from cancer screening and early detection, and
It's page 18, members.
oh, thank you. Excuse me. 1 from primary prevention and 1 from the dissemination RFAs. And I'll go through all 3 and entertain questions at the end, but feel free to stop me if your question can't wait. The first award is to the Rose in Houston. It's expansion of cancer screening and early detection services to rural and medical underserved communities. And you can see on the slide up here, the breakdown of the, I should have said this earlier, the 3 mechanisms for a total of a little over, well, $13.5 million. And all 8 of the projects are addressed all of the program priorities. Next slide. And this is the active portfolio. There's currently 71 projects active in the prevention program. And you can see by the color, it's the density of the projects for each county. And then on the right-hand side is the number of active projects by cancer type. And some of that, they add up to more than the 71 because some of them do two, different cancer types or even more than that. Not just cancer screening, it could be primary prevention. It could be there's 10 projects that are dissemination projects, but yes, people in every county in Texas are currently served by the portfolio. Next slide. And Dr. Rice, this is as per your request from last meeting, that it shows that these 8 proposed projects, this will be the geographic area that are covered by just these 8 projects. So it's quite the coverage for the 8 projects. All right, so back to my awards now. Sorry I got thrown off a little bit there. So the first project is a breast cancer screening program from the Rose in Houston. It's the Empower Her to Care project. And they propose to deliver breast cancer screening, diagnostic procedures, and patient navigation services to under-resourced residents in 45 counties in Texas. And that's remarkable. They employ multi-component strategies and interventions and focusing on really 3 different strategic categories: increasing community demand, community access, and provider delivery. Community engagement navigators will navigate patients through the complete clinical process, as well as schedule outreach and education activities and mobile mammography events. The Rose currently has a fleet of 5 mobile vans in which to accomplish all of this work in those counties. The next project is out of the University of Texas Southwestern Medical Center. It's a lung cancer screening project, and this project's called Saved by the Scan, Lung Cancer Screening and Patient Navigation in East Texas. And this project will leverage Moncrief Cancer Institute's existing framework, including community outreach and health promotion, comprehensive lung cancer screening with nurse-driven clinical navigation through follow-up and treatment where appropriate, supported by tobacco cessation education, counseling, and centralized reimbursement for local providers. Also includes shared decision-making, an important part of lung cancer screening. And this project will bring screening services across to 36 rural and underserved counties in East Texas. And the proposed program will provide multi-level support to ensure the completion of the screening process up to and including the start of treatment. The next project is from the University of Texas Health Science Center at Houston. This project, and I'll butcher the Spanish word, so I'll call it the PAP project, provides cervical cancer screening, diagnosis, and treatment of precancer and dysplasia through colposcopy and LEAP, which stands for Loop Electrosurgical Excisional Procedure. The underserved Hispanic population is at remarkably high risk for cervical cancer and has the lowest adherence rates of follow-up after abnormal screening. And this project will meet the needs of this population with accessible specialty services and education in the medically underserved areas of the greater Houston area. And these interventions will build on the other CPRIT-funded programs at the institution that provides cervical cancer screening to maximize the impact of the project. Next slide. The next project is another lung cancer screening program from the University of Texas MD Anderson Cancer Center. The aim of this project is to increase access to and completion of lung cancer screening services for persons who reside in the Tyler area who are at high risk of lung cancer due to past or present cigarette use. This, some key features of this centralized program include the reliance of primary care clinicians to identify and refer patients eligible for screening, provision of smoking cessation and shared decision-making by trained clinicians, and the use of navigators for management, patient tracking and follow-up, and quality improvement. This project will use a centralized model to deliver care and services through a collaboration between UT Health, East Texas, and the MD Anderson Cancer Center's Tobacco Quit Line and Decision Support Lab. Next, we have from the University of Texas at Austin, the Central Texas Colorectal Cancer Screening Program. This project proposes to comprehensively address colorectal cancer prevention and early detection in a 9-county area of Central Texas. This program comprises no-cost screening, diagnostic services, and patient navigation, and is designed to specifically address the barriers experienced by individuals in this region. Program components include a clinic-wide mail-out of FIT tests, fecal immunochemical test kits to eligible individuals, education and dedicated bilingual navigators to ensure completion of care pathways to diagnostic colonoscopy and treatment if there is a cancer diagnosis. The last cancer screening and early detection project is out of the University of Texas MD Anderson Cancer Center. It is another colorectal cancer screening program, and it aims to reduce colorectal cancer morbidity and mortality and promote earlier detection of colorectal cancer by partnering with federally qualified health centers and other nonprofit community clinics in rural and urban health professional shortage areas of Texas. And this is an expansion project, and this project will grow from serving 51 counties to 64 counties. The program is a multi-component intervention and is implemented at the patient, clinic, and system levels. Strategies include patient reminders, education, provider reminders, feedback and assessment, the reduction of structural barriers, and patient costs. And the project offers an initial FIT test and then or direct referral to colonoscopy for those at high risks. And then those with abnormal FIT tests are referred to endoscopy provider for colonoscopy and polypectomy. How do you say that word? Polypectomy? Getting rid of polyps. So I'll move on to the primary prevention of cancer project. It's from the University of Texas at Austin. This project proposes to incorporate an outpatient unhealthy alcohol use screening and intervention program to address the burden of alcohol-related cancers. Primary care patients at community care health centers and Lone Star Circle of Care, both FQHC systems with multiple clinic sites in Central Texas, will be screened using the alcohol use disorder identification test. It's called Audit Concise. And those who screen positive will then be referred to interventionists who will provide behavioral intervention incorporating motivational interview techniques tailored to the needs of the patient, and will set goals with the interventionist and the patient, and they'll be counseled on the link between alcohol and cancer. The interventionist will also assess patients for current tobacco use and the need for cancer screening. And the patient will then be referred to existing CPRIT-funded prevention programs that can provide smoking cessation resources, breast and colorectal cancer screenings. The last project is from the dissemination mechanism from the Baylor College of Medicine. This project proposes to develop an evidence-based blueprint, implementation guide, web-based education modules, and consultation service for expanding referral and access to low-dose CT scan screening to eligible patients in underserved areas of Texas for early lung cancer prevention. It's called Tex Care. The education course will include an interactive website and toolkit that will provide primary care clinicians with key information on implementing these screening projects in their practice and provide guides on strategies for patient follow-up. Web-based education modules will include active learning strategies, including case-based activities and videos and other infographics. Those are the 8 projects being recommended.
Thank you very
Question?
much. We got Mr. Margot.
Ramona, the last one, is it bilingual?
It is, it will
Okay.
be, yes.
Mr. Chairman?
Any other
Any
questions?
Yeah.
Dr. Hernandez.
Yes, thank you for the data. And I want to thank your staff also. Whenever we've asked questions before, at least from my experience, they've been very prompt to give us. So I'm going to ask a few questions. And if you don't have the answers, okay, email me the answer like you
Okay.
guys always do. So when these people are, whichever program it is, are test positive, and some it says they're being sent for treatment. Is it our understanding that, say it's, not picking anybody, say it's Baylor, who is a recipient of these screening, are they then obligated to take care of the patient all the way through? Or because if some don't have the funding and they colonoscopy and they do a polypectomy or removal of polyps, you decided, and it's still positive, they surgery, are they obligated to treat that patient? Or if they have no funds?
Yes.
They're obligated.
It's a requirement in the RFA that that CPRIT does not pay for cancer treatment,
Yes,
but they're required to navigate these patients into treatment. So
Right.
yes, the grantee is responsible.
And I see that there are some grants again for UT Austin. That's not a medical center. That's the University of Texas at Austin. That's what you mean, right? Or the University of Texas at Austin?
Yes,
That's the actual university, not
yeah,
a medical
that's who
center.
the grantee is.
Okay. So, but they're not a healthcare provider or doing this research. So where do those patients go that are, if they test positive for whatever they're doing or need help?
To
Where do
the
they refer
Dell
to?
Medical Center.
So they're referring to Dell. Okay, thank you, ma'am.
Sure.
Dr. Rosenfeld.
Just a quick question. There's been a lot of literature lately on colorectal cancer screening and FDA approvals. And I can't keep track of it. But I was just wondering, the colorectal cancer screening that you described uses FIT testing, but it doesn't use the genetic markers in addition to FIT testing. And the FDA also approved a blood test for colorectal cancer based on epigenetic changes. And I was just wondering on the blood test, if someone is it built into these studies that if someone doesn't want to do a FIT test, that they could get the FDA approved blood screening test for colorectal cancer?
None of our grantees have requested that that be the case. I'm sure that that will be coming. The Dr. Argenbright did speak in the advisory committee about the downside of the current blood test. The only blood test that is currently approved by the FDA is the SHIELD test. It is not good at detecting early cancers. It's good with late stage, but not very specific for early stage cancers. So none of them have yet moved to the blood tests, but genetic markers is an option. Several of our grantees will do genetic testing if appropriate.
Thank you.
Very good. Thank you, Ms. Magid. The chair now recognizes Mr. Carlton Allen, CPRIT's Program Manager for Prevention, to present the Texas Cancer Plan 2024.
Good morning. We're gonna be kind of demoing the live interactive website that we have for you all. So once that gets set up, we'll go through it. But first, I'd like to thank Ramona for her support and the time that it's been taken to develop this Texas Cancer Plan. It has been a labor of love, and there's been lots of support from a multitude of CPRIT staff members here, including her and Bridget, who I've worked closely with to make sure we have the most updated information and the correct content. And then also the number of stakeholders that I've had the opportunity to meet with, including those at the Department of State Health Services and other organizations across Texas to make sure we have the correct priorities for Texas. Their support and their information and data that they've provided is one that allows me to do this. So without further ado, this is the 2024 Texas Cancer Plan. So right now you're seeing the homepage. This will allow you to kind of get a feel for the major sections of the Texas Cancer Plan that will be easily navigated across the top. And if you scroll down, you'll get a feel for the section of how to use the plan. So this section will highlight the why the plan is important, what you can do, and how you can use the plan. And so if you go, and then if you have any questions about the plan, there's my contact information there. So individuals will be able to email me or give me a call if they have any questions. But if we go back to the top, we'll go to the next section, the executive summary. So with the executive summary, on this page, you'll get a high level overall feel of the Texas Cancer Plan. It's going to emphasize our state's commitment to reducing cancer impact and highlighting our statewide goals. And then on the right-hand side, you'll kind of see the goals at a glance there. So you'll see the new updated goals that we'll be looking at and measuring throughout this time period, broken up by different sections. And if you go to the top, we'll go to the next section. So this is the cancer burden section. When kind of gathering information and developing how we wanted this to look, there's some unique and very specific challenges that Texas faced that we decided needed its own section to really highlight what we're doing and why these different groups are important. And so you'll see here a rurality section that highlights the unique obstacles that rural Texans encounter and like limited access to cancer care and support services. You'll see a poverty section. This section addresses the social economic impacts that restrict access to quality cancer care. You'll see a race, ethnicity, and a gender section, which provides data on disparities among different populations that are at risk and including targeted interventions. An age section, and then along with that, so the age section will highlight the challenges that older individuals have, while also talking about the growing concern of early onset cancers, those individuals that may be younger than the recommended or guidelines, and we've seen an uptick in those early onset cancers. And then child, adolescent, and young adults. This group has some unique challenges, particularly with survivorship and reoccurring cancers or multi-cancers. And then the economic burden and uninsured section, which highlights where we highlight the lack of insurance coverage, but also the financial toxicity that cancer can cause on an individual or on a family. Lastly, with this section addressing the cancer burden. So we didn't want to highlight these without giving individuals beginning roadmap of what they can do to address the cancer burden in Texas. So you'll see things here like strategies that they could implement, such as community-based screening and education programs, what they can do to increase, such as adding NCI cancer centers and rural support services, what they can do to expand, such as expanding training and ongoing education programs for their providers, and then how they can advocate to increase community involvement in planning. The next section is the plan. So this is really the heart of the Texas Cancer Plan, and with this, as you can see on the left-hand side, the different sections, just like you saw at the goals at a glance, it breaks down those sections with each of the goals in those sections. And then within those sections, so if you click on the diagnosis and treatment section, within those sections, you'll see the goals that are associated with those sections. And if you click on those goals, you'll not only see the actual goal, you'll see the objectives associated with those goals, and then some very targeted strategic actions for different stakeholder groups that we thought could have an impact on addressing the objectives to help us meet those goals. So if you're a policymaker or work in the policy field, if you wanted to learn more about diagnosis and treatment and wanted to know what you can do, you can dive down in those strategic actions, and those are some of the steps that you could do to help us meet our goals as a state. The next section is one that is fairly unique, and with this being an online version and digital version of the Texas Cancer Plan, it allows us to have this interactive component. So with this, we use data from the Department of State Health Services and other sources, but we've essentially allowed individuals to dive deeper into cancer rates and whether those be mortality or incidence by different public health regions across the state. We also have it broken down by different race and ethnicities. And so it'll highlight the top 10 divided by male and female. And you can really dive deep and look down and hover over it and manipulate the data a little bit. And then the next section, you scroll to the top, is just the about CPRIT section. So this section just gives individuals an overview of CPRIT and what we're doing to help address the cancer burden with our services that we provide. So it gives a high level overview of CPRIT. And then lastly is our additional resources section. So this section we have it broken down by Texas resources and national resources, but it allows individuals that are on the page to have access to other resources that may help them or their programs reach the goals and objectives that they have. And so that is a high-level overview of the Texas Cancer Plan. We will be releasing the Cancer Plan next month, so December 2024. So we are very excited about that. And so I'm very excited about
thank you. Thank you so much for your efforts. It's obviously an enormous amount of work.
Thank you.
Remind us how often we update this in the state of Texas.
So the last cancer plan was done in 2018, and the cancer plan before that was done in 2012. So it's been about every 6 years. And as you all know, cancer changes quite a bit in that 6-year time frame, and so that's why it's taken this long to update this because there's been so many changes and we wanted to make sure that we got it right.
Very good. Question is Mr. Margot.
The previous iteration of this Texas Cancer Plan was just a printed document. Is that correct?
Yes, it was
So-
a PDF version that we still had a website, but with the way that we're doing this, it is going to be only a digital, but it allows us to then update the website and the Texas Cancer Plan if there are major changes or guidelines that we feel like either affect our goals and objectives or others should be aware of.
Yeah, unlike this, the previous one probably just gathered dust wherever it was or wasn't reviewed or whatever.
Yeah.
I do have one last question. I noticed your name and phone number at the beginning. Are you going to be available 24/7?
I mean, yeah.
Just wondering,
Yeah.
you know, I just
For-
wondering.
On
Okay.
call.
Yes. For
Okay.
this,
I think we should
I
test
will
that.
be available 24/7.
Other questions for Mr. Allen? Mr. Montgomery?
Thank you, Mr. Allen. First of all, congratulations. I know it's a lot of work. I noticed that some of the data are dated, 18 to 21. Is that because that's the last available set of data?
So when we were looking at data and working with our DSHS partners at the cancer registry, because of COVID and how that has affected the data specifically for that 2020 and even 2021 period, with consulting with the CDC, they recommend using a period of time instead of just a specific date. So if we did just look at 1 year, that 2021, it would have skewed the numbers a little bit. So that's why we looked at that time period to help us gauge where we were going and how we were doing.
Right, but are there data? I take it the data are not available for 22, 23, 20. Yeah,
That is correct.
takes a while to
Yeah.
generate those. So on the interactive map
Mhm.
with these services, do I take it that you can zero in on a county and find out what the incidence rate of lung, colon, other cancers are in that county?
So the way that we have it right now is by public health region. So you
Right.
can look at which county your public health region is in, and it gives a top 10 by male and female for that public health region.
Wow. For the whole region.
It's not by county, but on the cancer registry website, you can narrow it in by county.
Wow.
If you go into that area, district, what do you call it?
The
Will it
public-
have the data of, say, there's 9 counties in that area? Will it then stratify and tell you, there's 100,000 cancers in this region, this area, and of the 9, it lists all 9 counties and it breaks it down by county into that detail of who represents those, cancers and where they're at?
It doesn't break it down by specific county, just the whole region.
Right,
So-
just
So
a gross number of
it
where.
gives an average for the whole region.
But there is a way to navigate, I guess that's what he was getting at. If you can click, is there more drop boxes or clicks where you can go, well, if this central part of Texas has a high incidence of breast cancer and we want to know which of the 8 counties has the highest, is it able,
I see
is
what
this
you're
software able to do that?
This can point individuals to the website that can't do that. So
Okay.
because we worked with DSHS, if we can navigate individuals to that website and they can, if the data is available, they can look at their specific county and be able to look at cancer incidence and mortality and a number of other things.
Okay.
I'd just like to add that because of the population of so many of Texas counties, it's so small that often the county data is suppressed. So if you look at that county map on the Texas Cancer Registry, you'll see that much of the data has been suppressed because of the low number of cancers.
Briefly, if I may, a lot of the plan is backward looking. Do we have forward looking goals within the plan?
Yeah, so.
Okay, I apologize if I.
No,
I'm
no.
sorry.
That's it. That's right. Within the plan, with the objectives, we're gonna be showing individuals sort of the baseline of where we are, our target for where we want to go, and then also be looking at national rates if we have those available so that we can compare where we are on average with the US. Yeah. And
Thank you
then
very much.
because the plan is evaluated sort of mid-plan and at the end, we're hoping that we can incorporate that evaluation onto the website once it's available so that individuals can see exactly how we're doing midway through.
Very good. Mr. Taylor?
When you presented this to one of the subcommittees, I tried to keep my comments. My new goal is to keep my comments short. And I said, very cool. Which I think everybody understands. But as I've read the report now, I was wondering who wrote the content, because the content's very well written. And
That would be a lot of the work from my colleague Bridget, who's over here. She took my jumbled thoughts and made them coherent to be on this website, which took a lot of work.
well, it's truly very, very written and it's easy to follow. I can't wait to play with it. It becomes hard. So, good job,
Thank you.
everybody.
Yes. We're grateful for your hard work, your whole team. It's an amazing accomplishment, and hopefully keep track of this and you don't have to worry about it for 6 years.
Yeah.
All right.
Thank you.
your phone number.
Yeah, right. Okay, now turning to the action items. First, we will act on the award recommendations, and then we will vote on the proposed FY 2026 RFAs. Mr. Burgess has certified compliance for the prevention award process. It's my understanding that no oversight committee member has reported a conflict of interest with any of the prevention applications we will consider today. Are there any conflicts that have not yet been reported? Hearing none, members, you have the list of applications and grant amounts recommended by the Program Integration Committee for the Prevention Grant Awards. We will approve the PIC's recommendation if 2/3 of the Oversight Committee members agree. There are 8 prevention award recommendations. Rather than taking a separate vote on each grant application, I will ask for a vote to approve all the recommendations. If a member wants to consider one or more award recommendations separately from the vote on all of the slate, please make a motion to do so now. I will entertain a motion to approve the PIC's 8 recommendations for the following prevention grant award mechanisms: cancer screening and early detection, dissemination of CPRIT-funded cancer control interventions, and primary prevention of cancer.
So moved.
All in favor, vote aye.
Aye.
Any opposed? Hearing approval from at least 2/3 of the members, this motion carries. I will now entertain a motion delegating contract negotiation authority to the CEO and CPRIT staff and to authorize the CEO to sign the contracts on behalf of CPRIT.
So moved.
All in favor, vote aye.
Aye.
Any opposed? Motion carries. Members, closing out our action items for the prevention program, I will entertain a motion approving the 3 proposed fiscal year 2026 RFAs as presented by Ms. Magid.
So moved.
All in favor, vote aye.
Aye.
Any opposed? Motion carries. Members, Ms. Magid and Mr. Allen will be traveling to a cancer conference in Dallas, but before they leave, we will take up the Prevention Advisory Committee report out of agenda order. The presentation is in your packet behind tab 9. Ms. Magid, will you please introduce Dr. Shokar, who will present the Prevention Advisory Committee report?
First off, congratulations on your new award. It's my privilege to introduce Dr. Kiran Shokar, who is Professor and Chair of the Department of Population Health, Associate Dean for Community Affairs, and co-lead for the Cancer Prevention and Control within the Live Strong Cancer Institutes at Dell Medical School at the University of Texas at Austin. She received her Master of Arts degree from the University of Cambridge and her medical degree from the University of Oxford Medical School. And she's previously been at UTMB and Texas Tech University Health Science Center, El Paso. Dr. Shokar's research focuses on multi-level clinic and communication-based interventions that bridge the divide between public health, the community, and the healthcare system in order to address cancer health disparities among racial and ethnic minorities and vulnerable populations. Dr. Shokar.
Hello, okay. Hi, everyone. Thank
Hi.
you for inviting me to speak. It's an honor to be here to represent the prevention community in Texas and the Prevention Advisory Committee. I'm the chair of that committee, and the vice chair is Keith Argenbright, who I know is listening. Let's see, how do we advance here? Okay. Oh, there we go. Something worked. I think it's that one. Yeah. So first of all, just like to review briefly the Prevention Advisory Committee member roster. It's been updated. It's dynamic. We're adding new people representing new stakeholders all the time. So you can see the major academic medical centers are represented, nonprofits are represented, key groups across Texas. The State Health Services is represented, as is the American Cancer Society. And we have a couple of industry representatives as well. So the intent here is to have a broad swath of stakeholders at the table, helping us to think through the strategy and plans for the future for prevention in Texas for cancer. So I'm going to just review some of the data about current programs and activities, and some of this Ramona presented as well. So this slide shows you the prevention programs that are currently active by topic type. And you can see that there's screening, breast, cervical, colorectal, liver, and lung. All these are recommended by national bodies and national guidelines based on critical evaluation of the literature and the evidence for the fact that screening actually is beneficial, and that the pros exceed the cons of screening, because there are downsides to screening as well that have to be considered in the equation for figuring out which tests are going to be most effective, cost effective, and actually provide benefit to patients. And then there are 4 areas of prevention. These are known risk factors for multiple cancers. So the programming on the prevention side covers both prevention and early detection through screening, and also prevention through screening as well. And then this slide shows a little bit more type of grant. And you can see that a majority of the grants are focused on screening, detecting cancer early, or preventing it. And with a distribution including survivorship. You know, Texas has 1 million cancer survivors that still need very specialized care and attention with regard to preventing subsequent cancers, because once you have a cancer, you're at higher risk of a subsequent cancer. So that is a very important need that we have as well. This slide shows you the distribution for primary prevention. So this is preventing the onset of cancer from developing, and secondary prevention, which is detecting it early, and tertiary prevention, which is survivorship. So you can see that there's a pretty even divide between primary and secondary prevention, both of which are equally important in the strategy for reducing the burden of cancer across Texas. So this is a dynamic slide, because grants are being funded and kind of sunsetting constantly over the year. But you can see here, this slide is trying to show the pattern of funding over the last 4 years. Currently, there are 87 when I did this slide, but I think, Ramona, you said there were 91 grantees right now. And over the last 4 years, you can see the grants collectively provided almost 1 million services, 800,000, which includes education and training, which is really key and important, and navigation. So this is navigation to follow-up testing and navigation to treatment as well. And so pretty consistent with a little bit of an interesting pattern for some of the cancers. This slide, which was provided by Ramona and Carlton, shows you from the inception of CPRIT the number of services that have been provided. So with the support of funding from CPRIT, about 10 million education and clinical services have been provided across the state. And the map shows you that there were beneficiaries of this funding and the services in every single county of Texas, which is something that we should really be proud of. We're a very large state, 30 million. And with this program, which is very, very important, we're able to reach individuals all across Texas in all communities. So I think that's something really to celebrate and be proud of. So when you look at the services, about 4 million clinical services, they're listed there. You can see that we cover lots of different domains, screening, as we mentioned, primary prevention, but also genetic testing and genetic counseling for those that are at greater than average risk or may have a family history of cancer, which is an important risk factor for cancer as well as survivorship. And again, you saw from that map, sorry, this is a very sensitive thing. You saw from that map that, again, every county in Texas was covered by the services. And here there's a little bit more detail on some of the clinical services. You can see that we, through CPRIT, we're able to deliver about 2 million screening and diagnostic tests across the state. And as a result of that, we were able to detect and deal with precursors, about 40,000, 41,000. So the implication here, based on the data and the biology of cancer, is that we potentially prevented 40,000 cancers. And then, something else of importance that groups that we're trying to reach with CPRIT funding are the people that either have difficult access because it's not available in their community, or difficulty with access because they're uninsured. So our current uninsured rate is about 16%. So that's a significant number of people. So of those people, they're more likely to be the ones that had never been tested for or screened for cancer before. So we've reached almost 500,000 people that were able to access services because of CPRIT. And then we detected cancers as well. So 6,000, many of them at the early stage or at an earlier stage that would have happened if CPRIT did not exist. So we are impacting outcomes for cancer in Texas. So from the perspective of the Prevention Advisory Committee, so just want to highlight a few things that we were able to accomplish and that came out of our meetings. So one of the things that I already alluded to and mentioned actually is that we did expand the stakeholder groups that are represented on the Prevention Advisory Committee. We feel that's really important at the leadership level as well as at the programming level, because if we are going to really move the needle on cancer in Texas, no one entity can do it alone. No one stakeholder type can do it alone. Everyone needs to come together to address the challenges, identify the challenges, and also create the solutions as well. So that is a really important component of our work. I didn't do anything. Okay. CPRIT Innovations Conference. So this was a really great, and we really value this conference because it brings together the people that are working in the same area across the state in their own context. And we're able to share our experiences, share our challenges, and share our solutions. And it really builds community. And I think it's so important. The one we had, I think there was one that was missed because of the pandemic. So this coming together is really critical, and just want to kind of shout out that we really appreciate this, not just personally, but in thinking through strategy and creating those alliances that are going to be critical to continue this work and scale this work in a way that CPRIT hopefully will allow us to do going forwards. And then I wanted to highlight our role in the colorectal cancer treatment initiative. We were able to work with our advocacy partners at the American Cancer Society to help educate in the last legislative session, and for the American Cancer Society to advocate to set aside some funding for treatment for people that don't have insurance. There was a question earlier about access to treatment. That is a really critical component of the prevention programming, and it's a requirement of the RFA and a requirement to get funding that you have figured out a plan to get access to treatment for the uninsured individuals that you're serving. So this pilot funding is hopefully going to be able to demonstrate the benefit of having something like this funded in terms of facilitating people actually screening people, because, you know, there's a moral responsibility that if you screen someone that they're going to be able to have access to treatment. So having more support there to be able to do that is really important. So that was something members of the advisory committee worked on to partner with, particularly in terms of pulling the data together and educating legislators about why that's so important. And then another initiative that I'd really like to highlight is something that was a recommendation in a previous iteration of the Prevention Advisory Committee, which was to develop a focused statewide effort to leverage all the work that's happening in individual communities by individual programs to really think about how you scale, how you join together and how you scale those efforts across the state to really have a much larger impact than each individual entity work or program working on their own. So the idea behind this first coordinating center is that it's a convening entity to bring people to the table from the different stakeholder types, the grantees, as well as health systems, local health departments, etc., and to really bring them to the table together to share their resources, their expertise, their experience in education, in navigation, and also how they've resolved barriers, and to really understand and map with granular detail what the challenges are across the state in every county and region, and to begin to develop a plan for how we scale efforts and really make an impact for colorectal cancer screening. So this is, we hope, a kind of model for what could be done with other cancers across the state as well. And you'll see from the recommendations that that is something that the committee have been thinking about, what would be the next initiative that's kind of modeled on this initiative. So I did want to address, as we think about prevention and cancer outcomes, you know, it's a very, you know, there were some questions about, you know, how often are we doing the cancer plan, and we're looking back, but we do see patterns in looking back that could inform our efforts going forwards, and which I think is what Carlton and CPRIT have done in putting together the cancer plan. So there are certain patterns that we're seeing in the state that reflect national trends as well. So one of those is the rising earlier age of onset of cancers. So there are about 11 cancers, breast, colorectal, that's just some of them, endometrial and others, where what we've seen is that although rates may be declining in the older population above 50, they're actually increasing in the younger population. So that's something we need to think about and have a strategy for how we address, you know, all the work that's informed these evidence-based interventions that are being implemented across the state has really been done in that older population. So we need to think how we adapt what we've learned in that older population to the younger population. So a lot of work actually needs to happen there. And, you know, the younger population, their environment, their culture, the way they seek information, the way they value their values, their culture is very different to the older population. So we need to kind of make sure that we're thinking about that in the strategies that we're applying to that younger population, and not assume that what worked in the older population, in work that may have been done 20 years ago, not assume that that applies to the younger population. So we need to be thoughtful about that. The other trend that you see in Texas as well as nationally is the rising obesity-related cancers. So there are about 9 cancers that are very much related to, associated with obesity. We haven't figured out the mechanisms in all cases, but that is something that we're aware of. And you will note from the slate of grantees that there was actually only one grant that was addressing obesity. So that is something we need to think about as well. How do we encourage more grants? You know, it's a complex problem to address. It's multifactorial. It's very difficult to make changes in behaviors that are sustained. And, you know, there are all kinds of contributors, including environmental factors, food, etc., access to exercise, the way that we work. So it's a very complicated issue, but that doesn't mean that we shouldn't try to grapple with it, because we have to. Despite efforts, disparities in cancer outcomes remain. We know this, and you know, it's good to see that the cancer plan has a section that's stratifies by some of those areas where we know that the cancer outcomes are not the same across all populations, and we need to continue to be thoughtful and continue to advocate for creating programs that address areas where there are big differences in cancer outcomes. And then finally, the other trend to kind of pay attention to, and you know, earlier there was a question about this, is blood-based cancer detection. So with technology, we know that the testing space, the screening space, is going through a kind of a revolution of opportunity to detect cancer early using blood-based testing of different kinds. And so it's evolving, you know, that there's a test that's been approved by the FDA. There's a lot of tests in the pipeline that are in pilot stages of testing. And although the technology is there to detect certain things, we still don't have robust scientific data about the actual benefit to patients. So we need to stay committed to the scientific process to make sure that these tests are rigorously and thoroughly tested before they go into practice. And you know, as you know, a test gets approved by the FDA, and then has to be testing on populations in real world practice that's evaluated by national bodies that determine whether, you know, the balance of evidence, and then make a recommendation. The tests that we screen for that CPRIT funds come through the Preventive Services Task Force evaluation process. They make a recommendation, and then CPRIT endorses that. So that's the process. So we need to continue to ensure that, you know, we're not doing a harm by prematurely deploying tests into practice that haven't gone through that process. So we do need more understanding. We need more research to figure out what role these tests play in our armamentarium against cancer. So the PAC recommendations are, I was very excited to see the website, Carlton and team. Thank you so much. It's making the Texas Cancer Plan so accessible for everyone, anyone at any level, you know, so the patients can see it, community members can see it. It's just wonderful. And it looks really beautiful, actually, and very navigable. So I look forward to examining that in more detail. So the PAC is very committed to reviewing that plan and being aligned in its recommendations and coordinating with the recommendations in that plan. So that will be something we'll be doing over the next year. As I mentioned earlier, I think identifying the next cancer focus area for a statewide coordinating center to really scale efforts and have a meaningful impact on cancer outcomes for another cancer. We discussed several cancers. Cervical cancer screening was one. We really have the opportunity to eliminate cervical cancer through primary and secondary prevention in the state. So that could be an idea. And then, you know, the next bullet is about scaling efforts, promoting collaboration, sharing of the resources and experiences and best practices that the grantees and others have been developing across the state. So, you know, universally, we had a Q&A session asking for input from attendees at the innovation conference, that these were the things that people wanted to see happen. And I hope that through the CPRIT mechanisms and maybe another coordinating center effort, we would begin to, well, continue to do that work in really taking a step back and looking across the state for how we get to the next level. And then, so the other piece that is really important, and again, I think it was, I saw it in the Texas Cancer Plan, is access. So rural access to screening, the funding might be there, but there aren't the providers that are there in sufficient number to serve the communities where people live in rural areas. And then there's access based on not having funding. So those are the two areas, not only for screening, but the whole cancer pathway from screening, prevention, screening, treatment, and post-treatment care. The treatment piece is really huge because, as we all know, treatment is very expensive. And we really need a statewide strategy on how we enhance access to treatment. We all need to be thinking about it and how we advocate for that in a way to get access for people that don't have insurance for whatever reason. And then, we want to continue to accelerate research and capacity in prevention and control research. So there are some mechanisms on the scientific program side that we can leverage to continue to encourage that. And then, another thing that's really emphasized in the RFAs that we believe is important to continue and to think about even more is how we engage different stakeholder types, not just academic settings, but community-based organizations, clinics. How can we empower them to really apply for this type of funding to support prevention and screening programming in their own setting, as well as in partnership with academic health centers, which are primarily where the programs are based. And then, continuing a broad engagement with different stakeholder types. And again, I think the Prevention Advisory Committee really tries to have that value just because it's so important to tackle cancer because it's a very complicated disease. Okay, that's it. Thank you for listening, and I really appreciate the opportunity to speak with you.
Thank you so much, Dr. Shokar, for your excellent report. Do we have any questions?
I do.
Dr.
Yes, I do.
Hernandez?
Yes, Shokar, thank you, Doc. Very nice presentation. Recently there was an article from The Lancet, actually from your colleagues out of the UK, and they were addressing, and this UK Medical Research Council that put it out, and it addresses what you're referring to. Obesity is a major worldwide problem, but really it's big in the United States and narrowed down even bigger for Texas. And all the associated comorbidities come with it, diabetes, losing people's eyes, legs, and renal disease. And so you guys are going to have your hands full because the projections they see is into 2050 is not getting better. It's only going to get worse. So from a preventive standpoint, you guys have a lot of work ahead of you. And so I'm glad you guys are looking at this and getting out there. And you're right, the most needed areas of the people who are at highest risk, right? Because you're right, not everybody has the same resources. Not everybody eats, to be frank, where you and I eat, right? People can't afford groceries like most people can. And they have two jobs, typically. The economy's not what it should be. So it's like a perfect storm to get everybody, unfortunately, including adolescents, right? Because as a pediatric surgeon and obesity bariatric surgeon, I see it. They're not getting thinner, they're getting bigger. And the data supports that. So I applaud you, and I hope you guys really hit it hard in those areas because we need to keep them healthy so they stay as a very strong workforce. And they'll consume quite a bit of resources from a health perspective for the state of Texas. So thank you for your service.
No, appreciate that. And I would, you said you have a big problem. I would say we have a big problem.
Yeah.
And we all need to work together. As you noted and others have noted, it's multifactorial. Some of it is personal behavior because of circumstance, but a lot of it is the systems, the culture, the society, the food, the way food's produced, developed, processed, et cetera, et cetera. So it's a very complicated problem.
It is.
And we all have to come together across disease types, across stakeholder types, across, policy at different levels, et cetera, et cetera. It's an enormous problem.
Good job.
Thank you.
Mr. Montgomery?
Thank you, Mr. Chairman. Dr. Shokar, thank you for the presentation. Just one question on the screening outcomes. If 40,000 precursors detected, does that mean that those people will definitely get cancer or just have a proclivity to develop cancer?
Yeah, so it depends on the cancer. So, cervical cancer and colorectal cancer are the ones that we know best. There's very definitely a precursor stage, and not all those cancers will not all those precursors will move on to cancer, but we know that a good majority of them will. So it's not 100%.
Not
no.
100%, but it's pretty
Yes.
good indication. Okay,
Yes.
thank you very much.
Dr. Rice.
Dr. Sokar, thank you so much. Great to see you again. I wondered if, just for quick comment, if a late stage cancer presentation is slightly different than the rest of the cancer prevention story, and how would you think about, a goal that said in Texas, we want to decrease late stage cancer presentation by 50%. Just wondered if in your mind's eye you could share, like, how would you think about it, or is that a good question, and how would you approach such a thing, late stage cancer?
Yeah, very much so. That's exactly what we're trying to do with screening. We're trying to shift the stage to an earlier stage. So, as you know, late stage cancer often has symptoms, but it doesn't always. And symptoms can occur very late, or symptoms are very vague or not specific. And so a person doesn't recognize that something is going on. And this is particularly a problem in the younger onset cancer age, where often when they're diagnosed late. So yeah, I think that's what we're trying to do with screening, and we can definitely set goals around it. I mean, it's implied in doing the screening in the first place, but I'll be looking forward to the cancer plan. And in the previous iteration of the plan, there were some goals related to reducing by a certain % late stage cancer. So I imagine it's in the current plan as well. But it makes a lot of sense to do that, because that's how you impact outcomes, by diagnosing earlier. I don't know if I answered your question.
If there might be a different strategy for late stage versus earlier stage, and maybe the answer is no, but late stage is just a different species, obviously, and maybe a different population somewhat. I don't know, just a
Yeah,
thought.
I think that it's part of what we're doing with screening. A major part of what we're doing with screening is trying to shift the stage. So it's just as relevant for, stage 4 to 3 as 3 to 2. We're trying to intervene on it all.
Dr. Rosenfeld.
Wow, 2 million screens. That's an impressive number. 40,000 cancer free groups identified. Unbelievable. I won't speak, but not thinking about, thank you. The incidence of hepatocellular cancer in the valley. And it's well written, and a lot of people say that must have something to do with exposures to insecticides or pesticides or herbicides or others. And I was just wondering if there's any consideration for screening of these potentially toxic materials in exposed people, sort of like we would screen for asbestos. There's assays for all these chemicals, and as you know, it's also a subject of extensive litigation. So I was wondering, as opposed to screening for the cancer themselves, screening for the things that may lead to cancer, like herbicides, pesticides, and insecticides. Any ideas on that?
Yeah, I think we would have to do a lot more consideration of the cost benefit, because if you look at the number of chemicals, pollutants, etc., that are implicated in cancers of different kinds, there's quite a lot. And, there isn't, the association isn't 100%. If you're exposed, you're at greater risk of the cancer, but it doesn't mean that you're definitely going to get the cancer. So we would have to think about kind of resource needs and the benefit of that versus screening, where we know how to detect something that's actually happened but is early. So I think there would have to be a lot more it's complicated and probably outside the purview of a discussion here, but it's an interesting concept. But it all comes down to, how costly is it? What's the benefit, and what would you do? Can you reduce the exposure? Can you, reverse the exposure, etc.? So it's interesting.
Or another analogy may be vaccinating people against HPV to prevent
Right.
cervical cancer.
Yeah.
You're not detecting the cancer, you're preventing what causes the cancer.
Yeah. So,
And that's kind of the same
Yeah.
idea I'm trying to ask you about.
yeah, so I think, one of we would have to look at the data to look at, what is the attributable risk from that risk factor. For HPV, the attributable risk is very high. There are some cancers that are not HPV associated, but the majority of cervical cancers that occur are HPV associated. But if you look at it from the HPV perspective, we target the HPV that has the types that have the maximum association. But there are a bunch of other types that don't. So it depends what the data is available to assess the attributable risk and whether that would make sense economically and also in terms of logistics of doing that. So, but it's important. We certainly need to reduce environmental exposure to toxins, and that is a strategy that we should pursue anyway. But yeah, it's interesting. But yeah, you would have to look at each exposure type and kind of understand the science and the association and the causality to see. And if there are ones that meet the criteria that it would make sense, then maybe that would be an option. But
Mr. Chairman, I just have one more comment to the doctor. Is that okay?
Dr. Hernandez.
On your trend, your slide 9.7, given the mortality and the prevalence of these cancers, the graph you're saying for funding, if you had to do it over, given the prevalence and the mortality rate that occurs with these diseases, is this the order you would fund as far as a priority? Because I see the number one is colorectal cancer as far as funding mechanisms. If you had to do it over, given the prevalence and mortality and the associated cost and benefit, would this be the priorities in this sequence? In this order?
Yeah, that is, I mean, all the screening preventable cancers, there's
Yes.
5, and they account for about half the cancer cases.
Mhm.
So I think any movement we have in any of those is good. Number of cases and number of deaths, colorectal cancer is like second and third. Lung is the other one that is probably, there's more room for improvement in perhaps number of programs, but it's a complicated screen as well, logistically, and it leads to a lot of other testing as well. So
Of course.
so the setting and space in which that happens is, is complicated. So I think these cancers together cause almost half of all cancers. So I think that the strategy works. I mean,
Sure.
so I don't know.
Okay, Doc. Thank you.
Very good. We're going to move on. Thank you, Dr. Shokar. We appreciate your efforts very much. We're going to move on to item 8. This is going to be back under tab 5 of the meeting book. Chair recognizes Dr. LeBeau to provide the academic research program update. As a part of our update, she will seek approval for the proposed fiscal year 2026 RFAs for our consideration. Following her update, she will introduce the Program Integration Committee's grant award recommendations. Good morning, Dr. LeBeau.
Thank you, Dr. Cummings. Good morning. Before I begin, I'd like to direct you to tab 5 of the Oversight Committee meeting book for the Academic Research Program update, and to page 5 of the proposed grant awards book for a summary of the grant awards and the tables that I'll be presenting to you today. I'm delighted to present the recruitment award recommendations for FY25 cycle 25.1. If I could have the first slide, please. The Scientific Review Council reviewed 20 CPRIT Scholar nominations for FY25 cycle 25.1. And they recommended 5 awards for consideration by the Program Integration Committee. And that included 1 Rising Star Award and 4 Recruitment of First-Time Tenure Track Faculty Member Awards, totaling $12 million, as you see here in Table 1. The applications that were presented to the Program Integration Committee and proposed for consideration then to the Oversight Committee addressed the program priorities, as you can see on the next slide in Table 2. And these include all 5 recommendations address the recruitment of outstanding cancer researchers to Texas, as well as a broad range of innovative investigator-initiated research projects. One of the recruitments addresses drug discovery, and one works in computational oncology and analytical methods. So I'd like to move to the next slide and begin the description of the 5 recruitment recommendations for you. There were 5 Rising Star nominees that were submitted, and 1 was recommended by the SRC for an award. And that is Dr. Daniel Addison, who you see described on this slide. Dr. Addison is being recruited to UT Southwestern Medical Center, the Division of Cardiovascular Medicine, as an associate professor with the secondary appointment in the Cancer Center. Dr. Addison has already received considerable international attention for his work in the emerging field of cardio-oncology, which has informed our understanding of cardiovascular effects of targeted and immune-based cancer therapies, particularly in patients with hematologic malignancies. As evidence of his stature in the field, he has served in leadership roles on the Leadership Council and the Cardio-Oncology Councils for the American Heart Association and the American College of Cardiology. He has previously shown that the forms of heart toxicity that are caused by cancer treatment are the result of exaggerated responses of the body to natural defenses systems, and that they can be mediated by mutations in genes within blood cells that develop over time and cause inflammation. And this process is called clonal hematopoiesis. So he will continue to build on his platform of imaging and translational approaches to test the hypothesis that clonal hematopoiesis leads to an increased risk of heart toxicity, and that by blocking molecular pathways that are triggered by clonal hematopoiesis with targeted medications that reduce inflammation, that he can prevent and reduce the severity of this debilitating side effect without affecting the anti-cancer efficacy of the drugs. These are important studies that have the potential to lead to the identification of pathways that can be targeted for cardiotoxicity prevention, and may inform new immune-based paradigms for preventing cardiovascular disease in cancer patients. With your permission, I'd like to go through all 5 and then address any questions that you may have. The next 4 candidates are first-time tenure-track faculty member nominees. There were 14 nominees, and 4 were recommended by the Scientific Review Council for consideration. The first, if you go to the next slide, please. The first is Dr. Fengyu Liu, who is being recruited to UT Southwestern Medical Center, an appointment as an assistant professor in the Department of Pharmacology and the Simmons Comprehensive Cancer Center. Dr. Liu has an interdisciplinary background in structural biology and computer-aided diagnosis and drug discovery, computer-aided and structure-based drug discovery. She focuses on studying human transmembrane receptors and in elucidating their structural features. So both the structure of the normal protein and mutated proteins, and how drugs that are designed to bind to those proteins bind, and how they alter how those drugs modulate the function of the transmembrane protein. She will focus on targeting membrane enzymes that are involved in cancer progression in pancreatic ductal adenocarcinoma. And in particular, she is going to study 2 key pathways that promote cancer. The first is the Wnt signaling pathway, a pathway that promotes growth. And the second is the proteins that suppress ferroptosis, which is a type of cell death that is dependent on iron. And by suppressing ferroptosis, this would enable cell death to occur then in response to cancer therapies. One of the important things about her approach is that she can identify novel chemical probes that retain the desired clinical effects while eliminating the harmful side effects. And this could be a real game changer for targeting difficult to treat cancers. The next recruit is Dr. Zhangdong Liv, who's being recruited by the University of Texas Health Science Center at Houston. And he is being recruited to the Brown Foundation Institute of Molecular Medicine and has a very interesting background in that he has been studying cancers that contain mutations of the KRAS oncogene, which is one of the most commonly mutated oncogenes in cancer. And what he has found is that cancers that have mutations of KRAS are, as many of you know, are now sensitive to the new drugs that target mutant KRAS. However, they can develop resistance to these drugs. And the mechanism he discovered by which they do so is to undergo reprogramming of a process called proteostasis. And this is a dynamic regulation of the balanced and functional set of proteins that are within a cell or a tissue. And he found that cells that develop resistance to the KRAS inhibitors increase protein synthesis, and that by targeting them with a blockade, drugs that blockade protein synthesis, that they become sensitive again to drugs that target KRAS. So this may be a new mechanism for overcoming drug resistance. And this is what he proposes to do in his new laboratory, to uncover additional mechanisms of drug resistance to KRAS inhibitors and identify new approaches and drug candidates to overcome drug resistance to this new class of cancer therapeutics. Our fourth candidate is Dr. Norihiro Goto, who is being recruited to the University of Texas MD Anderson Cancer Center. He is an outstanding physician scientist who has substantial expertise in intestinal stem cell biology and in cancer biology. And he's being recruited as an assistant professor in the Department of Gastroenterology, Hepatology, and Nutrition. Now, one of the things that Dr. Goto discovered during his postdoctoral training is a mechanism by which early colon cancers initiate a process to avoid the immune system, to avoid detection and elimination by the immune system. And he plans to, he also discovered that the surrounding niche cells that surround the intestinal stem cells are involved in mediating this process and inducing this process of immune evasion. So now what he proposes to do in his own laboratory is to elucidate how the niche cells contribute to immune evasion and distant metastasis in colon cancer, and to develop novel therapeutic approaches that would target the niche cells. And so he's really addressing two major challenges in the treatment of colon cancer: immune evasion and liver metastasis. This concept of targeting niche cells would represent a breakthrough in cancer therapy. It would apply to other types of cancer, but also has the potential to improve the prognosis for patients with colon cancer. Our last candidate nominee is Dr. Zufeng Chen, who is being recruited to the University of Texas MD Anderson Cancer Center. And Dr. Chen is being recruited to the Department of Hematopoietic Biology and Malignancy. He's a very well-trained and talented fundamental cancer immunologist. And he is studying hematologic cancers with an emphasis on drug resistance and acute myeloid leukemia. And many of you know how immunotherapy has revolutionized cancer treatment, but the application to acute myeloid leukemia has been rather disappointing. And part of the reason for that is because AML cells can evade immune surveillance, and they do this by suppressing the function of the immune system by creating an immunosuppressive environment. And the overall goal of Dr. Chen's proposal is to understand the mechanisms by which AML dysregulates this process, how this affects immunotherapy, and how we can effectively reverse immune evasion to improve outcomes. And he has developed a very powerful target discovery platform and already found several key factors that that he believes are involved in this process in AML that he will study in his laboratory. From a therapeutic perspective, this has a high potential to allow us to use these novel approaches for discovering therapeutic targets. But it's also important because he's developed these toolkits that could be applied then to studying other druggable targets and to restore the immune system's ability to reject cancer cells. So it could be applied to other types of cancers in the future. So that concludes my description of the 5 nominees. I can proceed or address.
Do we have any
questions.
questions regarding the 5 grant award recommendations? Dr. Rice?
Make a quick comment, just something we discussed in the subcommittee, which I'll just bring forth here. It's kind of a, a wonderful thing that the rankings, the ratings that these all have are 1s or 1.1s, which we believe may be the best class ever, so to speak, of this rarefied kind of superstar recruiting class that we have here. And so we're thrilled with that. And we just call that out to recognize it, but also, I think call out that the give and take of, trying to balance one program versus another and the different options that we have. And we're, this is, we asked, I think, during the committee, and I'm not asking for a comment per se, but, it's, were there others? And the answers to the other were the others that were 1.3s that we would normally accept, et cetera. And we just didn't have room for them in this kind of budgetary construct we have. So I just call that out as a point for reflection, as we think about a retreat sometime or other kinds of interactions, which help us think about, what we're doing and how we're doing it and how we balance these, this richness of activity. The product development has now much more activity because it has much more application volume, et cetera. So, and that's a success of our program. But all these things begin to sort of, fill the gaps between what might have been opportunities for funding that we've seen in the past that we have to now narrow. If that makes sense. So that's just a comment.
Yeah, I think it does reflect the really stellar ability of our institutions in Texas to recruit really preeminent candidates and to nominate preeminent candidates. But you are correct that we left a number of candidates on the table who had scores below 2.0 below the fundable range in previous rounds of our recruitment reviews.
Very good. Dr. LeBeau, if you'll move on now with your proposals. Thank you.
Yes, if we go to the next slide, please. There's a few additional slides. So I'd like to present to you the proposed RFAs for fiscal year 2026 cycle 1. And these include the individual investigator research awards. And that includes our individual investigator research award, which has been a real foundation of CPRIT's individual investigator awards, as well as 5 targeted recruitment awards. These awards are not new. You have seen them in the past, so I'll just mention briefly that the targeted awards are for computational and systems biology of cancer, for cancer in children and adolescents, for clinical trials, research and conduct of clinical trials, for prevention and early detection, and for the analysis and study of early onset cancers, which you heard about from Dr. Shokar just a few moments ago. I think it's important to mention that the 5 targeted awards all address important processes and cancers that are relevant to the cancer burden in Texas, but also really important areas of cancer research and cancer biology today. I am happy to address any questions that you may have about those RFAs. If you go to the next, if you can just cycle through the next 2 slides.
Any additional questions based on the proposed RFAs? Okay.
The last discussion I'd like to present is just a brief overview of the academic research proposed priorities. I won't belabor the priorities shown at the bottom in black because these are priorities that the academic research program has had for a number of years. But we would like to propose for your consideration the addition of a new priority. And that is the one that you see at the bottom in red, cancer survivorship research to enhance the health and well-being of cancer survivors and caregivers. Just to remind you, I'll just say a few words. Today, there's over 18 million individuals, or about 5% of our population, who are cancer survivors. And cancer survivors experience increased physical, psychosocial, and economic adversities that are caused by a cancer diagnosis and the long-term effects of cancer treatments. These individuals are also at risk for late effects or secondary health problems due to their cancer treatment and therefore require long-term follow-up. Cancer survivorship research holds promise for reducing the side effects and mortality associated with cancer and its treatment. A cancer diagnosis and treatment also impacts friends and family members and the caregivers, who are often the main support network for the survivor. Caretakers for patients with cancer experience decreased psychosocial and social well-being. They have declines in mental health and overall health and reduced quality of life, and often related to an inability to work outside the home. For these reasons, there's a great deal of interest among cancer and other healthcare professional organizations in widening the focus of research, support, and care beyond the cancer patient and cancer survivor to include individuals who make up the support structure. There's a real opportunity for us to invest in this area of research and for Texas to help lead in this important area of research and care for cancer patients. Be happy to address any questions you might have.
Where do you anticipate a RFA or proposal to address that priority?
Yeah, I think that's a wonderful question. I think we have been working to expand and make it clear that cancer survivorship is a high priority for two of our existing RFAs, the Individual Investigator Award for Childhood and Adolescent Cancers and for the Early Detection and Prevention. And so we would love to see additional awards come through those mechanisms. We are also considering an additional RFA that may address cancer survivorship per se, because we are concerned that it may take a targeted and focused award to really draw attention to this, to this priority.
Excellent, thank you. Any additional questions? Very good. Okay, first we will act on the award recommendations, followed by a vote on the proposed RFAs. Mr. Burgess has certified compliance for the academic research award process. It's my understanding that no Oversight Committee member has reported a conflict of interest with any academic research application we will consider today. Are there any conflicts of interest not reported? Hearing none, members, you have the list of applications and grant amounts recommended by the Program Integration Committee for the Academic Research Grant Awards. We will approve the PIC's recommendation if 2/3 of the Oversight Committee members agree. There are 5 academic research award recommendations. Rather than taking a separate vote on each grant application, I will ask for a vote to approve all the recommendations. If a member wants to consider one or more award recommendations separately from the vote of all the slate, please make a motion to do so now. I will entertain a motion to approve the PIC's 5 recommendations for the following academic research grant award mechanisms: recruitment of rising stars and recruitment of first-time tenure track faculty members.
So moved.
All in favor, vote aye.
Aye.
Any opposed? Hearing approval from at least 2/3 of the members, the motion carries. I will now entertain a motion delegating contract negotiation authority to the CEO and CPRIT staff and to authorize the CEO to sign the contracts on behalf of CPRIT.
So moved.
All in favor, vote aye.
Aye.
Any opposed? Motion carries. Now, approval for proposed FY 2026 RFAs. Members, closing out our action items for the academic research program, I will entertain a motion approving the 6 proposed FY 2026 Cycle 1 RFAs as presented by Dr. LeBeau.
So moved.
All in favor, vote aye.
Aye.
Any opposed? Motion carries. Thank you, Dr. LeBeau. We'll now move to item 10, which is behind tab 6 of your meeting booklet. Moving on to agenda item 10, the chair recognizes Chief Product Development Officer, Dr. Ken Smith, to provide the Chief Product Development Officer's report. As a part of his update, he will seek approval for the proposed FY 2025 RFAs for our consideration. Dr. Smith will then present the Program Integration Committee's grant award recommendations.
Part of production, I've got it done.
Yeah, sorry about that.
Stuff, you know? Good morning, late morning. First slide, please. So, as Dr. Rice reminded me last meeting, I should go through the acronym so we know what the applications of the RFAs we're talking about are. So TTC is therapeutics, TDDC is device and diagnostics, TNTC is new technologies, and SEED are $3 million awards for companies. So you can see this doesn't, I don't have the slide that has the preliminary applications, but we received 90 preliminary applications, which I believe, I hate to use the word record, but it is the most applications that we've received at any one site. All these numbers, I believe, are records. So we're starting out with 90 applications. And I kind of want to explain some of the logistics because I want to thank GDIT, I want to thank Abria, I want to thank Michelle, and I want to thank all the PDRC as well as all of the reviewers because it's quite a task because the way we do it now, for those 90 applications, we had 8 panels of about 6 to 8 people, and they reviewed 10 or 11 applications. We took the top 3 from each of those panels. And so we had 24 applications that moved forward to full application review. Now, you had to put an application in, so one company didn't and another withdrew, so we ended up with 22. But for those 22 panels, there are 22 individually selected panels, and they're selected on the basis of what the company does, whether it's therapeutics, whether it's device and diagnostics, and may have separate people for diagnostics as opposed to devices. And so it's quite a logistical feat to actually put these 22 panels together. And these people do a tremendous job in looking. The critiques that come out of this are sometimes 30 pages long. And then that includes also, we have 3 hours of interview with the company. So I think we did it over 3 weeks in September. So like I said, I want to, thank everybody involved because it's quite a task. And so at the end of the day, we ended up with 22 full application reviews, $181 million. 9 were recommended for funding, and they went through due diligence. All 9 went through due diligence and were recommended for funding at a total of $68.8 million. As we've done the last 2 or 3 times, negotiated with the companies, reduced the amount by about 10%. So we have about $63.5 million for the 9 different companies. And at the end of the day, we still have about $9 million left over. I think our budget's around 72.6 or something like that. So we have about $9 million left over, which I'll talk about in a minute. Any questions about that? Okay. So in the interest of time and the interest of having me speak less, I brought the Reader's Digest version of the company awards. So we'll go through those quickly so that other people have time to speak. All right. So the first company is Curve. Curve Biosciences is relocating its headquarters from Mountain View, California to Dallas, Texas. And it's conducting a clinical utility study on blood tests designed for early detection of liver cancer in high-risk patients. The study will assess the accuracy of Curve's blood test in detecting liver, bile duct, and gallbladder cancers among 2,000 high-risk liver patients compared to the current standard of care. The current standard of care only detects about 33% of early HCC cases due to challenges in patient compliance and limited sensitivity for small tumors. The Curve test addresses this gap by specific biological markers unique to HCC, thus improving early detection accuracy. Second company is Marker Therapeutics. They're a prior grantee of CPRIT, and it's based in Houston, Texas. Marker is conducting a phase 1 clinical study to evaluate its therapy, MT601, in patients with metastatic pancreatic cancer following frontline treatment. MT-601 is an autologous polyclonal T-cell therapy designed to target multiple tumor-associated antigens. This study will assess the therapy safety and efficacy when combined with standard chemotherapy. The CPRIT funding will support efforts to enhance immune response in MPC patients with MT-601, utilizing the patient's own immune cells to potentially improve treatment outcomes. Third company is Telos, which is based in Dallas, Texas. Telos Biotechnology is developing Telovance, a platform designed to temporarily lengthen telomeres to enhance human cell and gene therapies. Telomere shortening limits CAR T-cell longevity, and Telovance addresses this challenge by selectively extending telomeres in CAR T-cells, improving their therapeutic potential without risk of immortalization. This funding will support the manufacture of Telovance in Texas and its integration into the CAR T-cell production process. The grant will also fund studies on platform safety, efficacy in animal models, and explore its potential application in therapies for lymphoma, myeloma, and melanoma. Metaclips Therapeutics is relocating its headquarters from Atlanta, Georgia to Houston, Texas, and it's developing Membrex, which is a personal cancer vaccine designed for recurrent resectable head and neck squamous cell carcinoma. The funding will support a phase 1A/B clinical trial at MD Anderson to assess Membrex, which uses patient-specific tumor vesicles with immunostimulatory proteins to activate the immune system, with a goal of preventing recurrence and metastasis. The relocation will facilitate local collaborations and support scaled production in Texas, aligning with CPRIT's objectives to advance innovative cancer treatments. Barricade is headquartered in Dallas, Texas, and is a prior CPRIT grant recipient, and it's advancing Taysen-15, a small molecule therapeutically designed for colorectal cancer patients with a mutation in the Adenomyosis polyposis coli gene, breaking a new set of teeth, found in 80% of CRC cases. This funding will support phase 1 clinical trials set to begin in the first half of 2025, focus on dose escalation, optimization, and determining a recommended phase 2 dose. The trials aim to build on promising animal studies and establish a safety and efficacious dose, potentially offering a targeted therapeutic alternative to conventional chemotherapy for CRC patients. Ipsilon is relocating its headquarters from Waltham, Massachusetts to Houston, Texas, and is advancing a bispecific TRCM CD3 engager-based immunotherapy targeting the CT83 antigen, which is expressed in several difficult-to-treat cancers, including breast, lung, bronchus, and stomach cancers. The funding will accelerate the development of Ipsilon CT83 targeted therapy with a focus on improving safety and efficacy for solid tumors. The relocation to Texas will contribute to the local biotech ecosystem. Can't believe I said ecosystem. And aim to provide new treatment options for patients with limited alternatives. Orphagen is planning to relocate its headquarters from San Diego, California to either Austin or Houston, and is advancing OR449, a novel oral small molecule inhibitor targeting adrenocortical carcinoma. This funding will support a phase 1 clinical trial at MD Anderson to evaluate safety and efficacy of OR44 in treating ACC, with additional potential applications for head and neck, lung squamous cell carcinoma. Positive results from this trial could enhance survival rates for ACC patients and contribute to establishing Orphagen as a key biotech player in Texas. Eisbach Bio is relocating from Germany to Houston, Texas, and it's advancing EIS-12656, a small molecule ALC1 inhibitor targeting tumors with BRCA1/2 mutations and other DNA damage repair gene mutations. The funding will support a phase 2 clinical trial at MD Anderson, focused on homologous recombination deficiency tumors in patients with BRCA1/2 mutations. The trial will evaluate EIS-12656 as a monotherapy, addressing limitations in existing PRP inhibitors related to toxicity and resistance. The goal is to establish a more effective treatment option for HRD patients in Texas and beyond. The last company is Arison, which is located in Austin, Texas, and developing a functional assay using single-cell protein sequencing technology to identify advanced non-small cell lung cancer in patients who are resistant to immune checkpoint inhibitors. The assay measures a particular ratio to gain insights into tumor angiogenicity, which could guide patient stratification for checkpoint inhibitor therapy. The CPRIT funding will support the assays, development, and objectives of advancing clinical trials and pursuing FDA approval to improve patient outcome and further cancer innovations in line with CPRIT's mission. Those are the 9 companies.
Do we have any questions regarding those
Got a
proposed awards?
I think we've discussed this before, and I don't remember for clarification purposes. Are we covering the relocation expenses at all? We don't. That's what I thought. Because you can apply to those respective cities, the state has incentives and everything else. So all this strictly goes to the grants. Okay. Just want to clarify that.
That's why we renamed, we had an award that was called relocation, but none of the money was allowed to be used for relocation. So we eliminated that.
Dr. Rosenfeld.
Mike's off.
Mike.
Thank you, guys. Just want to make a comment on the quality of the reviews and the reviewers. I went over each company's review and thought the reviews were thorough, insightful, and very targeted, and just hit the main points. And after seeing a lot of lots of applications to venture company reviews, these were the best reviews I've ever seen. So I just want to say thank you to the reviewers and how the process works.
Thank you. I'll pass that along because again, we couldn't do it without these people. And like I said, those reports and the good thing about the reports too, I mean, if you actually get money, right, not such a big deal. But if you don't get money, now they can use those reviews to actually reapply and actually use it maybe for SBIRs or some other type of funding. So I think in my mind that that's as important as funding these companies is helping other companies that don't get funded to help them draft a better application, do a better job so they can actually get funding as well. Maybe someplace else.
Dr. Smith, do you want to give us the proposed competitive cost adjustment RFA?
Yeah, so it's a little different, right? So the idea is that in the past 3 cycles, I guess, we've been doing some adjustment to the budgets downward, right? So as much as 30%, I think the original one we did was almost 30% for all the companies, and subsequently about 10%, 11, 12%. So the idea here with the 9.4 million that we have left is to actually fund, I won't let you sprinkle, okay?
Thanks.
We're trying to give some money to the companies that CPRIT's already funded, those that have achieved their goals and are on track to actually execute on their plans, is to give them additional money so that they can actually either one, finish because in a couple cases, like, give me an example where we reduced the goals and objectives because the funding was less, right? So in a manufacturing capacity, now they're ready to do maybe lentivirus when that was kind of taken out of the project. And another one, I can think of a phase 1 clinical trial or phase 2 trial where the number of cohorts was reduced. So here's an opportunity, if they're being successful, to give this money to them to continue all the work they've done. It'll still be competitive. It'll still be peer reviewed. And again, it's kind of, I think of a overall de-risking, right? So we've de-risked it in a couple ways. We only give half the money initially in the first year. So that's de-risking. We've reduced the budgets and that also de-risks. And now we can see a company that's actually succeeding and we can give them some more money with this. And part of the reason to do this too, to be honest, is logistically, the cycle we just did took everybody at CPRIT 3 months and it was all we could do. And so it's kind of a breather now that we want to go back out and visit with the companies. There's a ton of other things we'd like to do. And this to me is a way to have us do more of our mission while still helping companies that, you know, are under the CPRIT brand. So that's the idea.
Any questions for Dr. Smith? Dr. Roosevelt.
Quick one. When you reduce the funding, is there a concomitant reduction in the royalty payments?
The what? I'm sorry.
Is if you get reduced payments, do you have to pay less royalties
No.
if you're successful? So,
No.
okay, so those are unlinked.
No.
Okay.
That hasn't changed at all. And another thing too, I might add is that what the goal in many ways, what I try and accomplish in reducing the budgets is get them to participate more. I try not to have them reduce goals and objectives if at all possible. Now, you can see at a 30% rate, that's kind of hard to do. At 10%, it's more logical. I try and get them going, kind of back to your point about relocation. I try and get them to participate more in paying their personnel, things along those lines, so that we can spend more money on the project itself.
Very good. Thank you so much. Mr. Burgess has certified compliance for the Product Development Research Award process. Dr. Rosenfeld identified a conflict of interest with one of the applications. Are there any other conflicts of interest not reported? Members, you have the list of applications and grant amounts recommended by the Program Integration Committee for the Product Development Research Grant Awards. We will approve the PIC's recommendation if 2/3 of the Oversight Committee members agree. There are 9 Product Development Research Grant applications that we will consider in 2 motions. First, we will vote on the application on which Dr. Rosenfeld has identified a conflict of interest and must recuse himself. We will vote on the remaining 8 applications together in a second motion. If a member wants to consider one or more other award recommendations separately from the vote on the slates, please make a motion to do so now. I will entertain a motion to approve DP 250159.
Second.
All in favor, vote aye.
Aye.
Any opposed? Hearing approval from at least 2/3 of the members present and able to vote, the motion carries. I note for the record that Dr. Rosenfeld recused himself and did not vote on DP 250159. I will now entertain a motion to approve the PIC's remaining 8 recommendations for the following Product Development Research Grant applications. DP 250137, DP 250143, DP 250149, DP 250157, DP 250135, DP 250140, DP 250142, DP 250150.
Second.
All in favor, vote aye.
Aye.
Any opposed? Hearing approval from at least 2/3 of the members, the motion carries. I will now entertain a motion delegating contract negotiation authority to the CEO and CPRIT staff and to authorize the CEO to sign contracts on behalf of CPRIT.
Second.
All in favor, vote aye.
Aye.
Any opposed? The motion carries. Members, Ms. Doyle identified the board on November 15th that she seeks authority to disperse grant funds in advance to the 9 companies we have just approved for awards. Are there any questions for Ms. Doyle regarding her request? Pursuant to the General Appropriations Act, Article 9, Section 4.02, subsection A, do I have a motion to authorize CPRIT to disperse grant funds via advance payments upon the execution of the award contract and successful completion of the tranches to the 6 companies approved for awards today?
Second.
All in favor, vote aye.
Aye.
Any opposed? Motion carries. Members, closing out our action items for the Product Development Research Program, I will entertain a motion approving the proposed competitive cost adjustment RFA as presented by Dr. Smith.
Second.
All in favor, vote aye.
Aye.
Any opposed? Hearing none, the motion carries. Thank you, Dr. Smith.
Thank you.
Sure.
I just wanted to say, Dr. Smith, this has been a long time coming, especially for those of us that have been on this board for over a decade now. And certainly the construction of what you have been working on for the last year or so, 2 years maybe, to get us where we are today. I just don't want to go unrecognized, the phenomenal switch we've gone from, we can't find a product development company, I'm being facetious, to a 90 application cycle. Phenomenal. And so we want to say thanks and great work.
Thank you. And to the staff that works with you.
Yes, absolutely.
Dr. Cummings, can I add one thing to the record?
Yes.
And I'm sorry, I forgot to mention this earlier. In my letter, the PIC recommendation letter, there were 2 awards that had cents as part of their award amount. We failed to catch that. We don't typically have cents as part of, and so after I sent the PIC letter, we updated the slates. We rounded up. So it resulted in $1 more than what I had in my PIC letter. I'm saying this now so that we can add it in the minutes. So 5 years from now, when some auditor's looking and wanting to know why the number from my PIC letter is different than the number that you approved, this is the reason. Thank you.
So noted.
Are you asking for collection? Because I'm good for $1.
Of cents. All right, let's move on to item 10 behind tab 7. This will be the fiscal year 2026 program priorities. Ms. Doyle, please present agenda item 10, the staff recommendations for CPRIT's program priorities for the fiscal year 2026.
Thank you. As I noted in the beginning, this is the 10th anniversary of the adoption of the first program priorities. We have been doing this now for several years. The program priorities that you have for consideration for fiscal year 2026 are the same as the program priorities that were established for fiscal year 2025, with 2 exceptions. One is a change to the academic research program priorities that Dr. LeBeau already addressed in her presentation. The other change is to the prevention program priorities. We're removing one priority that was time limited. It was doing an assessment of 10 years of the program. Because it's no longer applicable right now, we're removing that. Both of those are discussed on page 2, 7.2 in your book of my memo. We also took this opportunity to report on the metrics that we track in terms of the program priorities. So we started doing this in fiscal year 2016. So our first program priorities were adopted in fiscal year 2014. So fiscal year 2016. And we did this at the behest of then presiding officer, Mr. Pete Guerin. So shout out to Pete if he is listening. We have always tracked the metrics by the number of awards that are made and the amount of those awards for each program priority. You hear all of the program officers do that. So I've included at tables that start at page 713, those quantitative metrics that are reported to you every meeting, but this is doing it on a cumulative basis and by year and by program. I'll also say, of course, we use this information, frequently throughout the year, and you've seen the results of what you have done in terms of program priorities, whether it's, I have one-pagers that I brought with me. We do a one-pager on childhood and adolescent cancer and all of the work that has been done on that. You've heard earlier this year about the core facilities map that we put out. We record and reflect this information and then include it when we talk with legislators and our stakeholders about what CPRIT's mission and how we are carrying that out. The last thing that I will note for you is, and and you see this every year, we also have all of the programs work together, not only on developing their own program priorities, but work across the programs to say what are some issues, what are cross-program priorities that we have developed. We don't track those on the same quantitative basis, but we do, and I've asked the programs to provide, and you'll see this starting at page 7.4 in my memo of examples from each of the programs on each of the cross-program priorities that have been addressed over the years and how those have come to fruition. That is all the information that I have. I'm happy to answer questions.
Does anyone have any questions for Ms. Doyle or the program officers? Hearing none, I will entertain a motion to approve the fiscal year 2026 program priorities. All in favor, vote aye.
Aye.
Any opposed? Motion carries. Thank you very much, Ms. Doyle. We'll move on to item 11 behind tab 8. The chair recognizes Ms. Doyle now to present her appointments to the Scientific Research and Prevention Program Committees.
Thank you. In my memo behind tab 8, you will see I have provisionally appointed 2 Scientific Research and Prevention Program Committee members. These will serve on the product development peer review panels. We say this every time we do this. I know the name is strange. It is from the very beginning, the 2007 legislation that our peer review panels are referred to as scientific research and prevention program committees, even though sometimes they also apply with our product development program. But we have nominated these two people. They were presented to the board governance subcommittee.
Are there any questions regarding these two appointments for Mrs. Doyle? Hearing none, is there a motion to approve the CEO's two appointments to the Scientific Research and Prevention Program Committees?
So, second.
All in favor, vote aye.
Aye.
Any opposed? The motion carries. We'll now move to item 12. We've already heard from Dr. Shokar and the Prevention Advisory Committee. Now we will hear from the Geographic Diversity Advisory Committee. Dr. LeBeau, will you please introduce Dr. Kang and to present the Geographic Diversity Advisory Committee report? Oh, excuse me, Patty Moore. Thank you.
Thank you. Good morning. It is my pleasure to introduce Dr. Kang. She is the Associate Vice President for Research and University Professor and Professor of Pediatrics at Texas Tech Health Science Center in Lubbock. She earned her bachelor's degree in pharmacy in South Korea in 1990, and her PharmD from the University of Colorado Health Sciences Center in 1998. After getting her PharmD, she has spent time, she joined the National Cancer Institute and NIH as a postdoc fellow. She was recruited to Texas Tech Health Science Center in 2008. She was promoted to an associate professor with tenure in 2011 and to full professor in 2015. Her research has been continually funded by CPRIT and NIH. She is a renowned pharmacologist and cancer biologist, accomplished in developing cancer treatments from laboratory science to clinical trials, especially in childhood cancers. She has worked with multiple preclinical studies and clinical trials consortia over the past 2 decades, informing the conduct of several clinical trials in both adult and pediatric cancers. So welcome.
Thank you. Thank you, Patty, for the introduction.
Let me get your microphone moved a little closer, please.
Sure. I was just thanking her for her kind introduction. It is my honor to be here, and thank you for having me to represent the Geographic Diversity Advisory Committee. Okay. The mission of GDAC, as you all know, is to advise the Oversight Committee and the staff on university's special needs and challenges in developing cancer research capacity in the locations far away from the cancer research centers in the major metropolitan areas, as you know. Oh, there you go. Oh. So GDAC committee is relatively new, as you all know. It was formed in the summer of 2021, and we held initially the monthly meetings for the first year, and then we shifted to quarterly meetings in mid-2022. Since the last Oversight committee meeting last February, we had 2 committee meetings. Also, we held a symposium, webinar-based symposium in June this year. Here's the Geographic Diversity Advisory Committee members. Many of you probably are familiar with some of the names here. Joe Heppert at Texas Tech University. I am representing the Texas Tech University Health Sciences Center in Lubbock. Rob Kirkin is representing the UTEP. Raj Lakshmana Swamy is representing Texas Tech University Health Science Center, El Paso. Ken Ramos is representing Texas A&M University, then Romo at Baylor University, and Sarah, who's the chair of the GDAC committee, Sarah Williams Blanchero at UTRGV. So I insert this figure, which shows the importance of geographic diversity as well as the role of the CPRIT. This is going to be the most important slide, in my opinion. So track institutions, the reason that it is very important is because, as you can see, the blue and red dots represent the National Cancer Institute designated cancer centers in the state of Texas, as well as you can see the dot in Oklahoma and New Mexico. So this geographically vast area is empty. So this yellow dots are the GDAC member institutions. As you can see, the West Texas part especially, UTRGV is moved towards the east right there a little bit, but it's supposed to be on the, not in the ocean, but supposed to be in the south part of Texas. But anyway, so these are representing West Texas and very South Texas, as well as some of the places. Overall, it's shifted, Baylor University and Texas A&M as well. So if you see the distance, I don't know if the laser pointer works here. Okay, maybe not. So the West Texas part probably representing about 16% of the overall Texas population. TTU and TTU-HSC is located a little over 300 miles from UT Southwestern, and also New Mexico, from New Mexico to TTU-HSC is about 350 miles or so. So meaning that some of the patients in that area, they have to travel very far to get the appropriate National Cancer Institute designated cancer center care, which initiates a lot of clinical trials, cutting edge technology, diagnostic, etc. So we wanted to make sure that they don't maybe potentially not have to travel in the future that far distance, because many of them are not willing to travel. That means that their diagnosis is going to be delayed. And it means that later stage diagnosis, which is connected to the poor prognosis of those patients as well. So anyway, UTEP and TTU-HSC El Paso have been very actively pursuing the infrastructure build and then recruitment as well. So is TTU and TTU-HSC in Lubbock, also UTRGV as well. So anyway, this is showing the importance of how those institutions that are funded by CPRIT is contributing to that area geographically for the cancer care of those people in the far area of the either West Texas or very South Texas as well. So TRAC, you heard about this term, Texas Regional Excellence in Cancer. The award initially started in 2021. It has been very highly successful at building capacity in cancer research across the state of Texas. The initial funding has been given to two institutions, two TRAC institutions. And then also it has been actively growing. The sizable initial TRAC awards, which was about $6 million over 5 years, that allowed us to build infrastructure as well as recruit junior faculty members to those regions as well. It's fast. Yeah. Okay. So this is to summarize all the TRAC awards since 2021 that has been awarded. So the total TRAC award-wise number of awards was 14. The TRAC CPRIT investment was about a little over $34 million. Number of patents filed using those TRAC awards was 5, and number of publications was about 48. So it's quite substantial, given that it was initiated in later 2021. It has been just about 3 years or so. So as I mentioned, 3 cycles of track funding has been awarded. The first one, the track funding was given to 2 institutions. As I mentioned, it's about $6 million over 5 years. The major focus of those track award is to build infrastructure to allow the cancer research in those institutions, as well as to recruit the junior faculty members. And then the second cycle of track award, which is the same amount that was announced in September of 2021, has funded 3 track awards. Those institutions include UTRGV, TTUHSC El Paso, and Texas A&M. And since then, they all recruited 3 junior faculty members, and they're actively doing cancer research in those institutions. The third cycle, which was recently awarded, initially was announced in January 2023 and funded 8 projects. So it's gotten a little bit more diverse from the initial 2 applications, which were focusing on the infrastructure and then junior faculty recruitment. So the third cycle, the funding types include institutional postdoctoral training award, because in those regions, we were having very hard time recruiting postdoctoral fellows. So the awarding amount was $850,000 over 3 years. The recipient was a UTEP track major instrument award, which was about $1 million over 2 years. The recipients were TTUHSC Lubbock, Texas A&M, and Baylor University. This allowed to purchase the equipment that is really necessary, big item, very necessary for the cancer research, and then also give enough time to train the personnel to operate that instrument as well. So third one is a pilot study award, which is about $200,000 over 2 years. This is not too much different from high impact, high risk, the current track, the CPRIT award, but more focusing on the geographic regions. So the recipients of this awards are UTRGV, TTUHSC Lubbock, and Texas A&M, and TTUHSC El Paso. So now what I'm gonna mention is the track initial $6 million awardee institutions are gonna be shown here. And I'm gonna showcase 3 of them who are doing excellent work with those CPRIT funding. So these are the 5 institutions that received $6 million over 5 years. The first 2 were the ones that received the initial first cycle of track award, which are UTEP, that is focusing on the center. Name is Center for the Study of Hispanic Cancer Disparity. Given that the population in El Paso, they have a majority of Hispanic population there, the center's focus on Hispanic cancer disparity is very justifiable. And then also TTUHSC Lubbock was another one that received for the first cycle as well. This center is focusing on the Texas Regional Excellence in Cancer Developmental Therapeutics Cancer Center. So this is focusing mainly pediatric cancer drug development. And then during the second cycle, Texas A&M Health Sciences Center, and then Texas Tech University Health Science Center at El Paso, and then also UTRGV received the track award, which were, again, $6 million over 3 years. Texas A&M is focusing on gene, environment, lifestyle interactions in cancer, and then also El Paso, similar reasons due to the population. They're focusing on the cancer outcome studies in Hispanics. And then UTRGV their center's name is South Texas Center of Excellence in Cancer Research. So as I mentioned, we did a virtual symposium in June of 2024 this year. So the purpose of this virtual symposium was to present each institution's representative research and promote potentially collaboration. By knowing each other a little better, they can actually have some commonality or needs of their smaller institutions to find the collaborators at other universities. So that was the purpose. And from each institution, we have 2 or 3 presentations on their focused research area and exchanged opinions and the potential collaboration chances, opportunities as well. So this was all facilitated by CPRIT, and the idea was also generated by the Geographic Diversity Advisory Committee as well as Dr. Lubo. So the first one that we want to highlight is UTEP, which was the initial awardee of the track award. So UTEP's application of cancer is mostly focusing on Hispanic cancer health disparity strategy. So to develop this strategy utilizing NIH's funding as well as CPRIT's funding, they're trying to build infrastructure that is necessary for the cancer research on Hispanic behavioral data and tissue collection. And then also community health workers are involved. And then they're trying to build the data analytics cluster and also imaging capabilities. Using these infrastructure, they're conducting many different types of research that is promoting the Hispanic health as well, especially in cancer. So funding-wise at UTEP, between 2021 and 2022, which is also including that $5.8 million of research funding from CPRIT. And then also in more recently, they received that postdoctoral training program award, which is about $0.85 million over 3 years. So using those or some of the independent NIH funding, their total NIH funding has become 11 different projects. Also from other foundations and other entity funding agencies, they received about 12 different grants. Also in 2022 to 2023, from NIH, they received about $8 million from NIH. Not 8 million, sorry, 8 different projects, and also 20 different other funded projects from other funding agencies as well. Here's something that I'd like to mention, which is very important. So the CPRIT allowed UTEP to recruit 2 outstanding junior faculty, Wei Quinn and Lu, and then Anna Erling as well. Each are focusing on pancreatic cancer or leukemia research as well. So the next institute that I'd like to highlight is the TTHSC, School of Medicine Cancer Center. Most of the members received from funding from CPRIT are the School of Medicine Cancer Center members. Anyway, School of Medicine Cancer Center has about 30 members across multiple clinical and basic science departments. Currently, we have about $36 million in active peer-reviewed external grant funding, and then $3 million in new extramural funding awarded in 2023. And total in the since the establishment, we received about $80 million in extramural grants. So multiple resources laboratories are within the School of Medicine Cancer Center that is supporting clinical trials as well as basic science research as well. One of the things that we'd like to really highlight about this resource that School of Medicine Cancer Center has is the biobanking. So from 2014 to 2024, which was initially funded by CPRIT as well, we collected over 6,000 adult and children with cancer, the biospecimen that are being used in many different countries, in 30 different countries and 600 different investigators as well. So the TTHSC in Lubbock track-wise, it was one of the awardees, one of the 2 awardees in the first cycle. Track-supported cores, including administrative core, flow cytometry core, South Plains Oncology Clinical Trial Consortium, and then also, as I mentioned, Cancer Biobanking Core, Pharmacokinetics, Regulatory Science Core, which is helping academic investigators to develop their product as a final cancer care product. And then we also have the Biostatistics and Bioinformatics Core as well. And those are the external advisory council members who are nationally renowned physicians and physician scientists as well. So track supported junior faculty accomplishment-wise, our first track supported junior faculty is Dr. Yangzong Bhutia, who's a DMB and PhD. She received the funding from track, and then 2 years later, she received a huge $1.5 million 5-year NCI grant. And so she actually graduated. So we call her track graduate. So she was replaced by another junior faculty. So also Dr. Nikat Nurin is a track supported junior faculty as well. She's a very recent recruit. Her expertise is in cancer bioinformatics. So she analyzed all the sequencing data to find out which genes are upregulated or downregulated in certain types of cancer, or related to prognosis, etc. So she is also a co-investigator. She's not a PI yet, but she's a co-investigator of $1.5 million NIH funded project as well. The second track faculty recruitment is our own in-house postdoctoral fellow who was promoted to an assistant professor who has conducted excellent research at our university. Paula Conero, he is working on novel drug targets for the osteosarcoma as well. Erin Barr, who is an MD, she's also track supported junior faculty. We are very proud to have her. As you probably know, recruitment of pediatric oncologists in the West Texas area has been very challenging. And she's an excellently trained pediatric oncologist with Dr. Sue Kohn in Chicago area. Anyway, so she is our pediatric oncologist who is also conducting as the chair of the National COG clinical trial. So that is a very big honor for us to have a chair of the COG conducting pediatric clinical trial of a ATM kinase inhibitor. So these are the CPRIT funded core labs at Texas Tech University Health Sciences Center, Lubbock. We have a cancer animal core and animal model core, which was funded about 6-7 years ago, I believe, which has improved our animal core facility tremendously using the CPRIT core. So we now have a bigger facility with a lot of animal biobanking work that we're conducting to support the cancer research. West Texas Pharmacology Core, as you can see, it was funded to me. I've been working very closely with the Children's Oncology Group nationwide, as well as to support academic researchers and small biotech companies that cannot afford the GLP quality pharmacokinetic studies, which is very critical in terms of drug development. So telomere maintenance mechanism lab, the director is Pat Reynolds, who is the director of the School of Medicine Cancer Center. He carries out molecular assays to find out certain telomere lengthening mechanism called ALT that is critical in terms of cancer phenotype. So certain patients with ALT phenotype has different responses to chemotherapy, et cetera. So he's conducting that lab and try to identify some of the patients with that ALT mechanism. Flow cytometry core, we received a track instrument award about a year ago, and that is also conducting clinical trial support via Children's Oncology Group. So far, less than a year of establishing that core with the cell sorter, which separates certain tumor types that express certain biomarkers. Anyway, so doing that, we should be able to tell whether certain treatment or treatment is going to be actually benefiting those patients or not. So it's all being conducted at TTHSC in Lubbock. These are mostly supporting the West Texas or the national clinical trials. So the third institute is TTHSC El Paso. So since they received the track, which is not too long ago because they received the second cycle of the track award, they have been supporting 3 junior faculty members. So one of them, since then, she received the R15 from NCI, and then also she received the American Cancer Society grant, which are pretty good. And then also Dr. Gadad, who received R16, and then also received the American Cancer Society grant, all based on the CPRIT support. And then the third junior faculty, who is Dr. Reddy, who's the site PI of NCI NSF Spark grant, and then also he's the PI of Coldwell Foundation grant. So these members are being supported by CPRIT track award. Using that track resources, they also established a tumor biorepository in that area, which is very important in banking Hispanic population's tumor samples. And then also they established the core service facilities in histology and imaging and cytometry at their university. So this is the new RFA that is ongoing. So there's 3 different types of RFA that is going. The grant deadline is December 10th, 2024. So not too much is remaining. Anyway, so track pilot study award. This is to check the feasibility of certain research. So this is about $200,000 over 2 years. And then the second one is track advancing innovative individual research award. So this is similar to IRA award for regular cycle, but the amount is $250,000 per year over 3 years. And the last one is track core facility support award. And this is going to provide about $400,000 per year over 5 years. So we are currently having a conversation with Dr. Lubo and within the GDAC as well to figure out how we can actually explore or create new funding mechanisms that is going to be helping those geographically diverse universities as well. Still, there's a lot of conversation is going on, but the challenge is that some of them are health sciences centers and some of them are regular undergrad academic campuses. Their focus is a little different. So HSC tries to focus on healthcare related issues and directly helping the patient related issues, etc. On the other hand, a little more focus is given to the infrastructure related issues for the general academic campuses. So we're kind of trying to filling the gap and then bridge them so that we can have more efficiently utilize the funding opportunities as well as the resources that will be potentially provided by CPRIT. So far, the CPRIT investment in track eligible institutions have been invaluable. As I pointed out, there aren't almost nothing. The scarcity of the population there is one thing, but the actual infrastructure difference is another thing. Because we do not have a critical mass, it means that some of the resources that are going to be providing help, really helps the institutions to grow, but the growth is not reaching to that level. To reach that parabolic stage of the growth, we have to have we have to reach the critical mass. So that's going to be one of the biggest challenging thing. So thus far, CPRIT investment in those track eligible institutions, these were resources were provided to expand the research on cancer, which has been great, and everybody's so grateful about the funding opportunities and the resources. And then also was providing it is providing the growth of the Texas workforce focused on the cancer research, and then also inclusion of the underserved population in basic and clinical research as well. And it's going to have positive impact on the health of the local population. So those are the main focus of the track awards so far. So I'll end here. If you have any questions, I'd be happy to answer.
Thank you, Dr. Kang, for your presentation. We have time for maybe one or two questions. Tommy, why don't I let you go first?
Thank you for your presentation. As I slowly wade into the cancer events in North Texas, I've been approached by several people who are on your list of track members. And I got the impression anyway, that they were feeling left out of the opportunities that were being presented. They were talking about the major centers getting a lot of funding, which is obvious. You may have already addressed that with this last slide, because my question for you is, do you think we're doing enough at CPRIT to get those opportunities out through RFAs, or do we need to do more? And like I said, you may have already considered that, or you may have heard that comment, because one of it was from a gentleman from Texas Tech that asked me that.
Right. So the money invested in the geographically diverse regions are not wasted for sure. But as I mentioned, so the initial growth, okay, so we have an 8-pound gorilla here. To make that 1,600-pound gorilla, it's going to be very hard, right? But we have a baby, which is about 50 pounds, right? Then to make that into a 100-pound gorilla, it's going to be a lot easier. So that investment by CPRIT is going to have a lot more bang for the region, in my opinion.
You can tell I'm a lawyer. That was a great explanation.
So
Go ahead, Dr. Rosenfeld.
two real fast questions. On your GDAC committee, you list Texas A&M, but do you mean West Texas A&M in Amarillo?
Texas A&M in College Station.
College Station.
Yeah.
Well, that kind of brings up to the sub question, and is that is there any representation of Amarillo in your committees?
Amarillo, Texas A&M, I believe is part of Texas A&M. So they can actually benefit through Texas A&M in College Station.
But
So it's the similar circumstances that TTHSC for Lubbock, in Lubbock, they have 5 different campuses. One in Abilene, one in Permian Basin, one in Amarillo. So all of those campuses are actually being represented by TTHSC in Lubbock.
I got that. Just caught my attention that when you showed the map where the locations were, there's no dot for Amarillo. So that was the first question. The other is really short. Has there ever been a CPRIT Scholar Award to any of the institutions in West Texas?
So TTU-HSC perspective, I don't remember other institutions. I'm pretty sure that there are. TTU-HSC received, TTU and TTU-HSC received 2 recruitment awards. One was awarded to TTU-HSC School of Medicine in Lubbock about close to 10 years ago. But unfortunately, we lost him to another state. And then the second recruitment was to TTU, School of Veterinary Medicine. She's with us. She's doing actively great research as well.
Thank you.
Dr. Hernandez.
Yes, very nice presentation. Congratulations. It's, this committee is very, we're dedicated to be sure that everybody gets the resources they need. And you guys got a drop pretty much of, water, and you guys grew this exponentially on multiple fronts. And it goes to show that we've had the discussion before you presented, Doc, where we know that if we disperse resources all over the state of Texas, that there are a lot of intelligent people, a lot of good campuses, and a lot of scientists that want to help out, but we need to step up as a committee and give you the resources. So don't be shy saying you don't, what exactly what Mr. Taylor's talking about. They're asking you flat out, what is it you need to really accelerate this project? And at the end of the day, you need funding, and you significant funding, not, I mean, it's nice what we did. And I mean, I'm glad we did it, but it's just a drop. It's just nothing. I mean, we give 16 million, we give a large amount of money to a lot of different reasons. I'm very proud that we do it, but it is, in order for us to accelerate this and grow this baby faster, not, in some minds, people want to wait 10 years. That's crazy. You need to do it now because you need the help now, not 10 years from now. So I implore you that be vocal with what you need. You speak for a lot of different organizations across the state, and we're here to help. And that was a great presentation. It just validates that what we're doing as a committee is absolutely right on the track. So congratulations to all of you.
Very good. Thank you. We're going to move on now. Thank you for your time, Dr. King. We appreciate you being here. We're going to go to item 13. The chair recognizes Ms. Doyle to present a Health and Safety Code Section 102.1062 waiver for CPRIT's General Counsel, John Ellis.
Thank you. Members, my memo is behind tab 10. So this is a conflict of interest waiver for our new general counsel, John Ellis. His wife's sister and her husband are both employees of Baylor Scott and White. Baylor Scott and White has applied before for grant applications. They've received awards from us. So this is really putting it on the record and being transparent about that relationship. I know you all, know our conflict of interest policies, chapter and verse. This is a professional conflict of interest when somebody is employed by a grantee or a grant applicant. In this case, in our rules, we have by second degree of consanguinity and affinity. So that's how they are captured in it. Neither of his in-laws have anything to do with any of the grants that CPRIT has funded, and they receive absolutely no grant funding in terms of salary support or anything like that. But this is just putting it on the record. And I've listed several of the things that we will do in order to protect us.
Any questions regarding this waiver? All right. Is there a motion to approve the proposed Health and Safety Code Section 102.1062 waiver for Mr. Ellis?
So moved.
All in favor, vote aye.
Aye.
Any opposed? Motion carries. Moving on to item 14, Chair now recognizes Ms. Eckel to discuss the proposed administrative rule changes.
Thank you, Mr. Chairman. The proposed rule changes are located behind tab 11 of your meeting books. We have 3 new proposed rule amendments for you today. The first one is 703.13. This rule change would adjust the grant recipient audit threshold from $750,000 to $1 million. Grantees who expend state funds at or above this threshold are required to submit an audit to CPRIT. We use the threshold that's set out in Texas grant management standards, which recently increased the threshold to $1 million. So we're just making sure our rules harmonize with what the Comptroller's Office has put out. And speaking of Texas grant management standards, the next proposed rule change to 70326 is a non-substantive change. We're just updating a citation that's still referred to the predecessor to Texas grant management standards, which was UGMS, or the Uniform Grant Management Standards. We just missed it when we went through our first round of updates a couple years ago. And lastly, the proposed rule change to 70326 adds a category of ineligible grantee expenses, specifically reimbursements that a grantee employer might provide to their employee for out-of-pocket healthcare costs if they are not made through an employer-sponsored plan, and Section 105 of the Internal Revenue Code. So those are all of our proposed rule changes. We will, if you approve today, we'll file them with the Secretary of State for publication in the Texas Register for public comment, and we'll bring them back to you at the February meeting. And that's it for the rules.
Any questions for Ms. Eckel?
I just think
Marta.
something of this magnitude ought to be the first item on the agenda.
I agree.
Thought you would.
I know, it's a shame. I can go on longer if you want, if you really want to.
703 has always been very exciting to me.
Members, is there a motion to publish the proposed changes to the Texas Administrative Code, Chapter 703 in the Texas Register?
Second.
All in favor, vote aye.
Aye.
Any opposed? Motion carries. Thank you, Ms. Eckel. Now we'll move on to item 15 and item 16. Turning to agenda item 15, the chair recognizes Ms. McConnell to present the Chief Operating Officer's report.
Thank you, Mr. Chairman and members. Good morning. It's still morning. Joining me is Grant Weaver, our new Chief Financial Officer. I just wanted to make sure he has the experience of sitting up here at the table today, because this is my last presentation as Chief Operating Officer. From February, he will be doing the Chief Financial Officer presentations over the same material, as well as all of the contracts. So I'm handing the baton over to him, but.
Welcome.
Thank you. So you have my report under tab 12. I mean, I'll just highlight that we have basically expended all of our funds for FY 2024 and through the final quarter. And we received another $266,000 in revenue sharing payments in that quarter as well, the majority of which came from Merck for the Wellereg royalties. And then we also reported our 5 performance measures to the Legislative Budget Board as required annually. I will note one of them, the companies relocating to Texas. We did not meet that projected goal of 3 relocations. There was only 1, but that is really dependent upon the companies that have been awarded, and then that are able to, if they do have to move to Texas, are able to complete all of the requirements that we have laid out. Beyond that, there's nothing remarkable in my report. I do want to highlight the fact that Dr. Abria McGee and I were in Houston last week. Well, she lives in Houston, but at Rice University on the 11th for some tours of their biotechnology launchpad and meetings with Dr. Vese and presentations from Dr. Bao and Dr. Moldren, who have a bioengineering collaborative. Dr. Bao is actually at Rice and Dr. Moldren's at MD Anderson, as well as from Dr. Gustafson, who's one of our CPRIT scholars. We also toured the Biosciences Research Collaborative building that Rice has right on the edge of its campus. and saw several labs of our CPRIT scholars that are housed there, as well as a core facility full of instrumentation. And so now I know what a sequencer looks like and does as a non-scientist. I just didn't know. But anyway, it was a really fulfilling visit and really remarkable to see what they're doing. And they really are collaborating because they do not have a medical school with their, many partners in the Texas Medical Center. So I just wanted to let you know that.
Thank you very much, Ms. McConnell. Are there any questions regarding the COO report? Moving on to item 16, Ms. McConnell, will you explain the recommended contract for conference planning and coordination services?
Thank you. Yes, under tab 13 is our recommendation to award a contract to Innovation Event Management, or IEM, for 100, and the amount is actually $190,788 for conference planning and coordinating services to assist CPRIT with the next Innovations Conference. And I do appreciate Dr. Shokar's shout out for the importance of that conference to our grantees. IEM is based here in Austin. They have extensive experience coordinating large-scale conferences for other state agencies, and they've done this statewide. So they have relationships with all of the major convention centers as well as large hotel venues. So we're hoping that we can have a choice by working with them of potential venues for the next conference. And so once they are brought on board, we will start working with them and issue an RFP for the venue selection, and then really work, once we have that venue selected, work on the entire program and bringing that conference to fruition. So I'm
Very
happy
good.
to answer any questions.
Any questions regarding the Innovation Event Management contract?
Are you guys going to be moving that conference around after all? I'm just curious.
Probably. I mean, that would be the idea. Last time we
Is that the directive we're giving them? Because that they need to choose. It can't be in the same location every year.
I mean, ideally, yes, we would move it around. And so
We haven't given them that. I just want to make sure, have we not given that direction that?
well, we haven't until we bring them on board.
Got it.
Yes, but yes, we will give
Great.
them that direction.
Members, is there a motion to approve a contract with Innovation Event Management LP for conference planning and coordinating services?
Second.
All in favor, vote aye.
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 Any opposed? Motion carries. Thank you very much to both of
I'm
you.
just curious with Mr. Weaver, you'll be available 24/7, right? for a call?
I gave you my word last night.
I just-
Got my number.
Want to make sure that.
I was waiting on your call last night. In fact, what happened? Certainly, both of them.
Item 17, this is, thank you both very much. This is for notating in the minutes that the state agency employment level CPRIT exceeding the FTE cap was presented by Ms. Doyle in her CEO report. Is there any questions in addition to what's already been presented? Very good. Let's move on to item 18. The chair recognizes Ms. Doyle to present her recommendation regarding the proposed chief scientific officer's salary adjustment.
Thank you. Members, I had sent you a memo earlier this week about my recommendation to increase the chief scientific officer's salary from the current level of $639,000 to $671,000. This is consistent with the approval that we have already received from the legislature in 2023. We had requested a 10% increase in the chief scientific officer's salary. They had approved that and given us the authority to do 5% in fiscal year 2024 and 5% in fiscal year 2025. So the Oversight Committee's already approved the first 5%. This would be the second 5%.
Are there any questions for Ms. Doyle? Members, is there a motion to set the exempt salary for the chief scientific officer position to the legislatively authorized $671,300 effective on or after December 1st, 2024? All in favor, vote aye.
Aye.
Any opposed? Motion carries. We're going to move on to item 19, the communications program update. The chair recognizes CPRIT's Communications Director, Mark Loeffler, to update us on CPRIT's communication activities.
Thank you, Mr. Chairman, members. I will be brief. You've got my memo, I believe, behind number 16. The items to highlight for this last period have been Texas Cancer Plan. We've been working very hard with Carlton and the prevention folks, and Bridget has done a fantastic job as well. I want to call her out. To create the look and feel and to create a Texas Cancer Plan for the first time that's online, accessible, and interactive. And so that's something that I think we're pretty proud of. I think we've gotten a good response so far. We still have quite a bit of work to do to get it up and running, but that's going to be published in December. So you'll see that when that link is final, it'll be public. We'll send that out. The other thing, of course, coming up is its annual report time. And Kristen knows we're very excited about that. So it's a great opportunity to talk about what CPRIT is doing. And this year, we're going to have a little bit of a focus on clinical trials. For the first time, we'll have a theme for the annual report. So look for that at the end of January. So we'll be hard at work on that. And also, I want to point out, if you'll see in your memo, we have had a slight uptick in some of our LinkedIn numbers, which is a positive sign. And we've also seen a little bit of an uptick in the number of web visitors and hits to the website. So I think that's all a good sign, trying to keep CPRIT from being the best secret in Texas. So I'm happy to answer any questions.
Thank you very much for your excellent work. As usual, we love all the updates, the net is being put out there, so we appreciate your efforts. Any
you.
questions for Mr. Loeffler? Mr. Taylor?
We talked about getting the word out on CPRIT, and I know the cancer report or cancer plan is going to be online. Is there a way to get all that information to the legislators and maybe with a QR code, something simple announcing it on the back? I was at a summit yesterday and QR codes is the way to cut down all those kind of stuff. And and the second part of my question is, can we put it out to the media in the state of Texas, all over the state of Texas? Same thing. I mean, cancer plan, they may not attribute to CPRIT, but I think if they show it comes from CPRIT, they put it in a good light, put us in a good light.
No, absolutely. And when the cancer plan is published, we'll send out that notification more than likely specifically to legislators' inboxes. So they'll have a direct link to the cancer plan. We'll also do a press release that'll go out to the media featuring the cancer plan. It's also going to go to a list of stakeholders throughout state government, all the folks that have helped contribute from HHSC, other agencies. So they'll get the cancer plan as well. Of course, it'll be posted on our website. So we'll spread the net as far and wide as we can on the cancer plan, because it is something that is very important. As you've heard Dr. Shokar mention earlier, it is critical for a lot of researchers across the state. So we'll spread the word on that.
Dr. Rosenfeld?
Love your daily emails.
And I do want to compliment Justin Rand. He never really gets as much attention as he should. He's very, very dedicated in rooting through all the media available today and finding a lot of articles that it'd be easy to miss. So compliments to him.
Just a quick question. Seems like about a year ago, we had a discussion at an oversight committee with Wayne about having a booth during a legislative session. So kind of a CPRIT day in the legislature. And I was just wondering if there was any follow-up to that.
So we've certainly talked about it internally. I don't know that we will I don't know that we'll have something like CPRIT Day. Certainly, we have many of our advocate groups. We'll have, cancer days where they talk about what CPRIT has done and how they support the work and would like the legislature to continue to support CPRIT. We do more of the outreach to legislators directly. At this point, my staff and myself, we have visited with nearly half of the senators, and now we'll expand that once we're past the election. We'll talk about whether a booth is the right opportunity for us, and think about that.
Focus so much of legislators is during the session, there's lots of groups that come through and schools and everything. So Wayne mentioned that different entities have a booth for a day or something like that. Just an idea.
Thank you. Thank you, Mark. Thank you for your work.
Thank you.
All right, let's move on to item 20, the internal auditor report. I guess we've saved the best for last. The chair recognizes Mr. Graves to present the internal auditor report. Good news only, please.
It's all good news when we're an internal audit, right? My report today is fairly brief. It's really just a status update of the plan that was approved by you all in August. We have 3 main audit activities this year: post-award grant monitoring, P-card advisory audit, and then a non-grant expenditure audit. These will all be fairly focused this year. We've looked at them broadly over the last decade that we've been your internal auditor. The post-award grant monitoring, we have started planning and we'll kick off our field work in January. It's really going to focus on the review of financial status reports and grantee reimbursements. The non-grant expenditures will happen at the same time and focus purely on that, all the expenditures of the agency that are not grant or payroll related. Then the P-card and advisory will look at and provide some recommendations for improvement on how to best utilize the state's P-card rebate program. That'll be in February. And then we'll have follow-ups over the 2 final audits, prior audits in May. And it's just a status update of what our timing is going to be, when you can plan to expect to see reports in the future. That is all I have for you today. Any questions?
Well done. Any questions for Mr. Graves? Excellent. Thank you for being here. So this moves us to the end of our meeting, item 24. We will not take up standing agenda items 21, 22, or 23. Turn to agenda item 24. Our next regular Oversight Committee meeting will occur on February 19th, 2025. If there's no further business and no objection, the chair moves to adjourn this meeting. Is there a second? All in favor?
Aye.
The motion carries. The meeting stands adjourned at 11:47 a.m.